Welcome to EMTprep Pulse Check, the podcast where we help you sharpen your knowledge, ace your exams, and stay field ready. Whether you're prepping for the NREMT or looking to stay sharp in the ever-evolving world of EMS, we've got you covered. Each episode brings educational insights, real-world case reviews, and expert tips to boost your confidence, both in the classroom and on the call. Let's jump in.
Today, we're focusing on musculoskeletal injuries. Let's get started with a lecture brought to you by Josh, one of our content creators. And then we'll wrap up with 10 multiple choice questions for a review.
Welcome. So this course is going to offer an introduction into musculoskeletal injuries, which is a really broad category of injuries that tend to occur in our trauma patients. So a quick introduction to the course here, to the type of injuries and just general trauma care. The musculoskeletal system is there to provide structure, movement, and stability to the body. It includes your body's bones, muscles, joints, tendons, ligaments, connective tissues. Anything that forms your body's structure or supports your movements is under the realm of the musculoskeletal system. Injuries to the musculoskeletal system are very frequently encountered in our trauma patients because trauma patients are the ones who are going to break bones. They're the ones who are going to get bruised muscles. They're the ones who are going to get injuries to the musculoskeletal system. Emergency treatment always needs to focus on life-threatening injuries first. A lot of the injuries we're going to cover today really just come down to wound care and don't necessarily save the patient's life. So always remember that when we encounter life-threatening injuries, they always get priority over splinting an extremity fracture, for example. A big principle in trauma care that we always want to understand is that we want to reduce scene time in our critical patients. All of the research that has been done in critical trauma patients points to one thing that really makes the most difference in patient outcomes, and it comes down to the amount of time it takes to get the patient from where they are into the hands of a trauma surgeon and specialists who can actually fix them. So like I said, a lot of the things we're going to cover today are not treating life threats or not saving the patient's life. So a lot of the assessments we're going to cover, a lot of the interventions we're going to cover are things that can and should happen en route to a hospital. We want to fix life threats. We want to treat airway, breathing, circulation problems right away. But once those things are assessed and managed, we move those patients to the emergency room because we don't really fix trauma patients in the field. We can stabilize them, but trauma patients need the care of a trauma surgeon, and transport should always be our priority. We got to get them in the hands of specialists who can fix them. So we'll go ahead and start the course off here with some of the anatomical background to the musculoskeletal system, and we'll start with the skeleton. Obviously, there are a lot of individual bones in the human skeleton. We're not going to cover each and every one. We could have a 3-hour course going over each and every bone in the human body. We're really going to cover some of the big picture stuff, some of the major structures that we want to be aware of so that we can effectively treat our patients and understand what's going wrong when we find injuries. Your skeleton, first and foremost, allows our body to take the structure that it does. Without our skeleton, we would not form the shape that we do. We would just be a lump of tissue that wouldn't really be able to move around and wouldn't really be recognizable. Your skeleton also protects a lot of your internal organs, especially those that are housed within your rib cage and within the protection of your pelvis, and it allows for movement. We would not be able to move in the ways that we do. We'd have much more difficult lives if we would not have bones that form the structure that they form. Very important to also understand that your bones are very involved in production of your blood cells, and bones are vascular organs and they do bleed. A lot of folks don't intuitively understand this. We think of bones as dry organs, but understand they bleed just like any other organ. When we fracture a bone, that bone typically bleeds just like any other organ if it was broken. That bleeding isn't usually life-threatening. It's usually not any life-threatening quantity until we get into really big bones like our femurs and our pelvis, which can absolutely lose a life-threatening quantity of blood. So that's just an important concept to understand about our skeleton, is that our bones are vascular. They do bleed because they are there to produce blood cells. That is one of the big tasks that they form. We break up the skeleton into two big portions. The first is the axial skeleton, which includes the skull, the spine, and the rib cage, and then the appendicular skeleton, which includes the shoulders, hips, and the extremities. It includes everything other than the skull, spine, and rib cage. And this photo here does a really good job of showing the two major divisions of the human skeleton. So we'll start with isolating the skull here. The skull is also separated into two parts. One of those is the cranium, which is the a part of the skull that houses the brain, and then we have all of these facial bones that form our facial structure. Most of the bones in the skull are very firmly connected by these suture lines you see here. All those squiggly lines connecting those individual bones we call sutures, and the bones of the skull should not move in relation to one another. They form one solid structure, but there are many individual bones you can go and learn that are all fused together by these suture lines. The only movable bone in the skull is the mandible or the jawbone. That's what allows us to eat and talk and do all the things that require us to move our jaw. But the vast majority of the skull is a rigid structure from fused bones along these suture lines. Next up is the spine. The spine is a column of dozens of individual bones that are called vertebrae. We can break up those vertebrae into a few sections. The first is the cervical section, or kind of the neck area. Next is the thoracic section, kind of the upper back region, and then the lumbar region, which really is in the patient's lower back. There are 7 cervical vertebrae, 12 thoracic vertebrae, and 5 lumbar vertebrae. A lot of folks remember these numbers as the times for breakfast, lunch, and dinner. Breakfast at 7, lunch at 12, dinner at 5, just as an easy memory tool to remember how many vertebrae are within each section. Below the lumbar vertebrae, we have our sacrum, which consists of fused vertebrae, and our coccyx, which also consists of fused vertebrae. A lot of folks know the coccyx as the tailbone. Your spine houses and protects the spinal cord, in addition to providing the structure that we need to, have our tall features that we have. Within your spine goes your spinal cord. All right, it's a very important structure, and that's the reason that injuries to the spine are considered very concerning, because we can have damage to that spinal cord, damage to our central nervous system, and that's not a very good day for the patient when their spinal cord is damaged from a spine injury. Moving on to our chest, the rib cage is something a lot of folks are pretty familiar with. Your average textbook patient is going to have 12 pairs of ribs. They have 12 ribs on either side. Some patients have more, some patients undoubtedly have less, but that is your average human is going to have those 12 pairs of ribs. Your ribs connect to your thoracic vertebrae in the rear or posterior, and most of them connect to the breastbone or the sternum and the anterior of the patient. In between your ribs are intercostal muscles that support chest wall motion. They allow us to breathe, they allow our chest to expand and contract, and they become very important, especially in really severe cases of respiratory distress, where the patient might rely on those muscles to move their chest to allow them to breathe. Your chest cage protects the organs of the chest. Your heart and lungs and a few other really important organs live under the protection of your rib cage. It also supports ventilation. We would not be able to breathe in the way that we do if we did not have the rigid structure to our chest that we do, because we breathe through this negative pressure process that requires a firm structure to allow our lungs to expand and contract. Moving on to the arms. Your arms include the humerus, which is the main long bone in your upper arm. In your forearm or your lower arm, you have your radius and your ulna. There are 2 bones there that kind of swivel back and forth to allow us to rotate our hands. The radius is always the bone attached to the thumb. It does not matter what direction your thumb is pointing, your radius is connected to your thumb side there. Your wrist bones are known as carpals, your hand bones are known as metacarpals, and your finger bones are called phalanges. Some folks will also refer to those as digits. Next up, we can isolate the shoulder girdle or the pectoral girdle, and that's the joint that we call the shoulder. There are 3 bones involved in that joint. One of those is the humerus, which is that upper arm long bone. One of those is the clavicle, which we know as our collarbones, and one of those is the scapula, which we know as our shoulder blade. Scapula, also known as shoulder blades, clavicles, also referred to as collarbones. Moving down towards the legs, the femur is the main long bone and the thigh. Those are really big bones. Remember, bones do bleed, and femurs will actually bleed a lot. You can lose a life-threatening quantity of blood through even one femur fracture. Your lower leg consists of your tibia and your fibula. A lot of folks mispronounce fibula because they want it to rhyme and they will say fibia, but it is your tibia and your fibula that compose your lower leg. Your tibia is your main shin bone. Your fibula is that bone off to the side, lateral to the tibia. Your ankle bones are known as tarsals, whereas your wrist bones are known as carpals. Your ankle bones are known as tarsals. Your foot bones are called metatarsals, and your toe bones are once again referred to as phalanges. Both your finger and toe bones are known as phalanges. You can isolate the hip joints here, otherwise known as the pelvic girdle, and this includes the femurs and their contact with the pelvis. This is another girdle joint. It just refers to the style of joints, but the hip joint is an important one to understand which bones are touching there, because hip injuries are relatively common, especially in elderly folks. So that is the skeleton. Obviously, we could dive a lot deeper and talk about every single individual bone and all the shapes and different types of bones, but those are some of the major structures we want to be aware of to understand the background of some of the injuries that we're going to talk about later. We can now talk a little bit about muscle tissue. You might know this, you might not, but there are actually 3 types of muscle tissue in the human body. The first is what we call skeletal muscle. Usually when people hear the word muscle, this is what they think about. This is the muscle that is under voluntary control. These are the muscles that we build when we go to the gym, and it supports voluntary motion. Skeletal muscle is there so that we can choose to move around. Another type of muscle is called cardiac muscle, and the terminology there is probably a clue to what it does. That is muscle that is only found in the heart. Some of the cellular physiology is a little bit different when we look at cardiac muscle, but that is confined specifically to the heart tissue. The final type is smooth muscle, and this is typically found in hollow organs. This is also an involuntary muscle along with cardiac muscle. We don't choose when our heart beats and when it does not, and we don't choose when our hollow organs contract and relax. That's the main goal of smooth muscle, is to control the size of blood vessels and lower airways and other hollow organs. When smooth muscle contracts, usually an organ will get smaller, or the lumen within it, the hole within it, will get smaller. When smooth muscle relaxes, the lumen size gets bigger. So we have control over our blood vessels. Smooth muscle will cause our blood vessels to become bigger or smaller in accordance with the need of our bodies. We also have smooth muscle in our lower airways. That's really important to remember, that can cause our lower airways to become bigger or smaller as well. So that was just a quick introduction into some of the relevant anatomy, some of the big picture stuff that'll help us to understand what might be going wrong with our patients. We're going to dive into the realm of trauma assessments now. This might be a great introduction for you into the trauma assessment skill sheet, and so we'll go for it here. What I'm basically going to do is I'm going to go head to toe on the patient. We're going to go through all the line items in that trauma assessment. I'm going to talk about some of the injuries we might find along the way and how to manage those injuries if we are able to manage them. So the treatment of a trauma patient, once we actually get hands-on, once we've gotten all the scene size up stuff out of the way, we're wearing our BSR, the scene is safe, once we actually start to go to work on the patient, we always start with addressing immediate life threats. Things like life-threatening hemorrhage or obvious airway compromise are things we're going to address immediately. If you walk up to a patient and there is bright red squirty blood coming out of their thigh, you're going to treat that first. That is our number one priority, any immediate threat to the patient's life. We then begin our primary assessment, which involves assessing and managing problems with the airway, breathing, or circulation. Those are those golden ABCs, which are always our major treatment priorities, and we always give priority to those problems, right? You're not going to splint an extremity fracture if there's an airway problem to be managed. You always focus on those life-threatening conditions and the airway, breathing, and circulation problems. When in doubt, you assess and support ABCs and get the patient into an emergency room, and ideally a trauma center when we talk about major trauma. After your primary assessment comes your secondary assessment, which is meant to be a head-to-toe physical examination of your patients, which should identify any and all injuries that are present. Whether or not those injuries that we can manage or do anything for, we want to identify every injury that we can find that that patient has in our head-to-toe examination, which is our secondary exam. We should identify most life-threatening conditions in the primary assessments, but if not, we should identify those in the secondary. And if you ever find any life-threatening condition, any life-threatening injury, it is to be addressed immediately. The last thing we'll say here is very important, is that rapid transport is a huge priority in any and all major trauma patients. All of the research that's been done in trauma care really points to one thing that makes the biggest difference in improving outcomes for trauma patients, and that's the amount of time it takes to get them from where they are to a trauma surgeon or to a facility with specialists that can actually fix them. We don't want to hang out around on scene for too long. We assess and support ABCs, and a lot of the things that we're going to talk about today can and should happen en route to the emergency room. Splinting an extremity fracture, while it's an important skill, does not save a patient's life, and so we really push for rapid, expedited transport in any serious trauma patient. We do ABC stuff on scene, we do BLS ABC stuff on scene, and then we move the patient into a hospital. We move them towards an emergency room, ideally a trauma center, to get their injuries fixed, right, to actually save their life. So we'll go ahead and start. We'll run down every line item in the trauma assessment skill sheet, starting with our size up stuff. That includes the obvious PPE, BSI, making sure we're wearing our protective equipment, and making sure we ensure scene safety. We can form really bad habits when we just put our hands up in the air, do kind of a jazz hands move and say BSI, scene safe. So that's not really doing anything for us, right? We really do want to give a good thought to the equipment we're going to be wearing. If you're working outside around traffic, that's going to extend to wearing a helmet and a safety vest. But at a bare minimum, when it comes to trauma stuff, we want to be wearing EMS gloves, we want to be wearing safety glasses, and if you're in the middle of a pandemic like we are right now, probably even more than that. All right, so make sure we're wearing our equipment, make sure the scene is safe, right? If there's violence involved, make sure law enforcement is there to secure the scene for you. Make sure pets that might be aggravated that you're going to work on their family members are secured and not going to hurt you. All right, make sure we are working in a safe area. If there's traffic involved, we need to position vehicles to block traffic. These are things that we want to think about when we're en route to a call and when we're first showing up on a scene. We don't just want to say BSI, scene safe, and forget about it, but oftentimes that's kind of what we end up doing, at least in scenario land. We then assess the mechanism of injury. This is usually information you get en route to a call. We don't usually just show up on a mystery call where we have no information. We know that it's a vehicle crash or a fall, a gunshot wound, something of that nature. But we want to know that, right? And when you're going through scenarios, when you're testing, you want to verbalize the mechanism of injury is this. Next up is requesting additional resources. This is always a continuous thing you want to think about. What extra resources do I need? If you're an EMT basic, ALS is a great place to start. If you show up on a major trauma patient who might need a higher level of care, maybe they need to get RSI'd and intubated, and that's not something you can do, you're going to want to call for those resources early. It's very easy to disregard people, send them back home, send them back to their stations when it turns out we don't need them. It's not ideal to be needing people when you wanted to have them on your scene 5 minutes ago, right? So we want to request resources early on. Even when we're en route to the call, we want to think about what extra resources we need. Advanced life support. If they need extrication, we might need a fire department. Things like that are really important to think about when we're en route to these types of calls. So when we move into treatments, the first step in trauma care is to consider cervical stabilization. That doesn't necessarily mean you have to have a partner, hold C-spine, but it's a great place to start, especially when you're testing, and it's something we want to consider early on. C-spine injuries are life-threatening. If we manipulate the neck too much with a patient who has a C-spine injury, we can kill them from that manipulation. So make sure we're having a partner hold C-spine when there's trauma to make it appropriate. We then assess the level of consciousness. We show up on our patient, and we want to use that AVPU scale early on, right? We want to know if they're alert, if they're conscious and talking to us, if they're only responding to verbal stimulus, if they're only responding to painful stimulus, or if the patient is completely unresponsive, right? We want to know their level of consciousness and their level of responsiveness right away. We then want to assess for a chief complaint in a conscious patient. If they're talking to us, we say, hey, my name is this, I'm here to help you. What hurts you the most right now? Unconscious patients or folks who aren't relaying information, we immediately look for immediate life threats. So a blood sweep is something you might be taught to do to look for life-threatening bleeds, which are our big life threat we want to assess right away in major trauma patients. Beyond that, we look for anything that is an obvious threat to the patient's life right away. Life-threatening bleeding is something you might look for. Obvious airway compromise, that sort of thing. Anything you would consider an immediate threat to the patient's life is going to be addressed immediately. Next, you want to consider exposing the patient. Keeping patients warm is a really big principle of trauma care. We want to prevent hypothermia. We want to prevent low temperatures because those lead to very negative outcomes in trauma care. We really want to make sure we're keeping our patients warm. That comes with basic treatment for shock. But we do need to look for injuries. So think about cutting open your patient's clothes, opening them up so that you can look for hidden injuries, and at least make sure you're going to be able to inspect every area of the body there. Number one is hemorrhage control, right? This is an immediate life threat. If there is life-threatening bleeding, We're going to address that immediately, so we'll just briefly touch on how to control hemorrhage. There's really only 2 steps to hemorrhage control these days. We used to have this very long treatment progression. We would try direct pressure, then we would do arterial pressure and elevation of the wound. These days, it's direct pressure and then straight to whatever is going to fix it if we have something to fix it. So the initial management of hemorrhage isn't going to involve direct pressure. Direct pressure is not just putting your fingers on a wound and pressing in gently, right? Direct pressure is really firm pressure. Put as much of your body weight into that wound as you can. Put the palm of your hand with some gauze on it and put as much pressure as you can onto that wound. Because if a patient is bleeding to death, we need to make every effort to get that to stop. So be firm, be aggressive when it comes to direct pressure and hemorrhage control. If hemorrhage does not work, if it is extremity bleeding, we apply a tourniquet as our second line treatment. For junctional areas where extremities meet the torso, like the groin, shoulder, potentially the neck, we can consider wound packing. Those are skills in and of themselves. They're kind of outside the realm, strictly speaking, of musculoskeletal injuries, but those are important skills to practice, right? Tourniquet placement and wound packing are really big. Elevation of wounds is not routinely recommended anymore. You might get taught to do so. It's probably not going to hurt your patient, but most of the research shows that it just isn't effective at reducing hemorrhage. It's going to make the tiniest, tiny difference, and it's really not worth spending your time elevating the extremity. We want to go for tourniquets and wound packing. Unfortunately, life-threatening bleeding in the chest and abdomen can't really be controlled with anything beyond direct pressure, but that's our treatment progression. Direct pressure, and if needed, a tourniquet, and wound packing for junctional areas. So once we have successfully managed any immediate life threats, namely life-threatening hemorrhage, we're going to move on into our ABCs. We're going to assess and support airway, breathing, and circulation. When it comes to airway, the 2 line items on the skill sheet say to open and assess the airway and insert a simple adjunct if needed. When we're opening the airway, we want to make sure we do not manipulate the C-spine, right? If someone is holding C-spine, if we need cervical stabilization, we definitely don't want to go for a head tilt chin lift, right? The jaw thrust is really the way to go for your first line airway maneuver there, and just make sure we're taking cervical stabilization seriously, because a C-spine injury can be fatal. It can take away the patient's ability to ever breathe on their own again. We're then going to open the airway. We're going to suction as needed. If we open up that airway, we find it full of blood and vomits, we're going to suction those contents out. Remember, anytime you suction, you're probably going to have to suction again. That blood is coming from somewhere, the vomit is coming from somewhere, and it's going to keep coming. So when we have to suction, when we need to manage the airway, it's always a process of continuous reassessment. And if you have crew members, you're going to park a crew member on the airway to make sure that their job is to keep that airway clear. We then insert a simple adjunct if needed. In scenario land, it's usually needed. In real life, it may or may not be. But we want to assess that patient's airway, right? If they're speaking in complete sentences, they're conscious, speaking in complete sentences, they probably don't need an adjunct. If they are unresponsive with snoring respirations, they absolutely do need an adjunct, right? So assess the airway real quick, determine the need for an adjunct. We want to avoid a nasopharyngeal airway or NPA where there's major facial trauma or any bleeding coming from the nose, because those are common contraindications for an NPA, because we don't want to insert it straight into the patient's brain if there's damage there behind the nose. When it comes to OPAs, we just have to make sure our patient does not have a gag reflex. In most of the scenarios you get, they will not. But that's not going to be the case in your real trauma patients. At the end of the day, if they do not accept an OPA and there's a contraindication for an NPA, we're going to have to do the best with what we have. In some cases, we can't use either, but we need to make sure we try, right? If you insert an OPA and they gag, simply remove it and move on. Do your best to support ventilation without it if we're not able to use it in that given situation. And remember, this is a continuous process of reassessment. Right? If they lose their gag reflex down the line, we can then go ahead and insert an OPA. If they have one in and they start gagging on it, we remove it. If our airway gets full of fluids, full of vomit or blood, we continuously suction. Airway is always more important than anything else. If you find yourself splinting an extremity fracture and you look up and you find an airway problem, it always gets priority. The airway is always the biggest thing. And when it comes to testing, a good recommendation, if a test question ever references the airway, the answer is usually whatever supports their airway, right? It's a very important concept in emergency medicine. We've got to be very aggressive and very successful with our airway management. Next up is our breathing, right? We're going to assess breathing, ensure adequate ventilation, provide oxygen as necessary, and manage any injury that compromises breathing. So when it comes to assessing breathing, we're looking for the rate, right? If it's not between 12 and 20, we're going to start breathing for them. We're looking at the rhythm. If it's regular, that is normal. If it is irregular, that's a big indication of a severe brain injury. We're looking at the quality. Is it concerningly shallow or deep? Does it seem labored, right? If it's not good quality, we might go ahead and start bagging them as well. And we might consider listening to some lung sounds. Lung sounds in trauma patients are a little bit quicker. We don't necessarily need to listen to every single lobe. Most of the time we get initial lung sounds in trauma patients, we're just making sure they are moving air through each lung, and we can follow up later on with some more in-depth lung sounds if you would like to. Next is ensure adequate ventilation. Bag them. If they are not breathing adequately, we're going to breathe for them. 1 breath every 6 seconds with enough volume, minimum pressure, minimum volume to generate visible chest rise. If you aren't getting that chest rise, keep working until you do. We don't move on until we ensure adequate ventilation. Then consider supplemental oxygen. Oxygen is something we can be pretty aggressive with in trauma care, and if there's ever any doubts, you should err on the side of giving the patient supplemental oxygen. We can titrate it down the line when we get an oxygen saturation, but if a SAT isn't readily available in a critical trauma patient, you should generally give them supplemental oxygen as a rule of thumb. Then we manage any injury that compromises breathing. We do not have to manage a flail chest. That is no longer standard of care. We will manage a sucking chest wound. That is probably the biggest type of wound that you might encounter here that is going to compromise breathing. If there is penetrating trauma to the chest, you're going to want to cover that with an occlusive dressing taped on 3 sides, or ideally with a commercial chest seal device. But make sure you manage any sucking chest wounds. It's probably the most common one you will encounter, especially in scenario land. Moving on to C for circulation, we're going to check for a pulse, we're going to check their skin, we're going to reassess any hemorrhage control measures and control any other major bleeding that we find that we haven't already, and we're going to treat for shock. So when it comes to checking pulse, we once again want rate, rhythm, and quality. We want to see if they have a good heart rate, if they have a good regular heart rate, and if we're getting a good pulse or if it's maybe thready or weak. We're going to take a look at their skin, which gives us great information about circulation. We're looking for color, temperature, and nature. Is their skin pink, warm, and dry? Is it pale, cool, and clammy, or is it somewhere in between? Skin is a great thing that we want to check. Capillary refill is another great option for assessing their skin and assessing their circulation. Next is control any major bleeding that you haven't already. Hopefully, if you walked up and found bright red squirty blood coming out of the patient's thigh, you have already addressed it. But if you find any other major bleeding, address it now. Don't get worried about small lacerations or capillary bleeding, any light oozing of blood from a small wound. We don't necessarily need to divert our attention to that. But any life-threatening bleeding, any major bleeding, we're going to address immediately as soon as we see it. And then initiate shock management as appropriate. If your patient looks like they are hypoperfused, if they're showing signs of clinical shock, we're going to treat for shock. That's a 3-pronged treatment. We're going to lie the patient supine. We don't routinely teach elevation of the legs. We definitely don't teach Trendelenburg anymore. Lie the patient flat on their back. Give them supplemental oxygen, right? Err on the side of being aggressive with oxygen, at least initially, and take every step you can to prevent heat loss. The last one is the one we forget to do too often, so form good habits early on. Make sure you are covering that patient in a blanket. Do everything you can to keep them warm. Get in the habit of getting the heater going when you're working trauma calls as well. Get used to sweating in the back with these types of patients because we've got to keep them warm. After our ABCs comes a quick GCS, right? The line item on the skill sheet generally says to make a transport decision according to their GCS, and a GCS is important regardless. Your NREMT skill sheet does the ABCs. Other protocols you might learn will extend that out even farther. It'll go A, B, C, D, and then to E. D, when it is present, it stands for disability, and it really cues us in for a quick neuro exam. We're going to check the patient's pupils real quick if we haven't already, and we're going to get a brief GCS if we can. This is your GCS scale. Remember, this is scored from 3 to 15. 3 is the minimum. That is a completely unresponsive patient. 15 is a patient who is A&O times 4. They're alert and they're breathing and they're doing just fine, at least as far as their mental status goes. 4 total points for eye opening. If they open their eyes, if their eyes are open, right, spontaneously, that's a 4. If they open their eyes to verbal, that's a 3. To painful, that's a 2. If they don't open their eyes, that's a 1. This tends to go hand in hand with our AVPU scale. For verbal, if they are oriented, they get a 5. If they're confused, right? So if they slip up on our alert and oriented questions, that's a 4 for verbal. If they use inappropriate words that don't make sense, we don't care if they use profanity, we're looking for words that don't make sense to us, that's a 3. Incomprehensible sound, so moaning and groaning, that's a 2. No verbal response whatsoever is a 1. When it comes to motor, if they obey commands, they can give us a thumbs up, put 2 fingers up, hold out their arm so we can get a blood pressure, whatever we want. They obey commands, that's a 6. If they give us purposeful movements, that's a 5. That's when they reach up, they grab for stuff, that's purposeful movements. If they withdraw away from pain, so they try to get away from any painful stimulus, if we do a sternal rub or a trap squeeze, they will withdraw from that stimulus, that is a 4. Inappropriate flexion, or decorticate posturing we call it, is a 3. Abnormal extension or decerebrate posturing, that is a 2. If there is no motor response, that is a 1. Scaled from 3 to 15, this is one we gotta commit to memory, because doing scales like this under stress is very difficult, right? So we've got to commit it to memory. We have to practice it as often as we can. But a GCS scale is going to drive our transport decision that tells us how high of a priority patient this is going to be, which is usually a priority patient. At this point, we're going to start moving the patient to the emergency room if we have an ambulance with us. So next up comes our vital signs. So understand, at this point, everything else can happen on the way to the emergency room. If we are a transporting agency, this is the point where we start moving the patient towards the hospital, and we do everything else en route, because our number one priority in major trauma patients is getting them to the hands of a trauma surgeon. So we'll talk about our initial vital signs. At a minimum, we need a blood pressure, heart rate, and respiratory rate. And oxygen saturation is another one we really want to get, so we can titrate oxygen appropriately and make sure we are supporting good oxygen saturation. And then any other vital signs as appropriate, right? If your patient seems like maybe they were altered before the event, definitely get a blood sugar on that patient. See if a low sugar might have caused them to crash their car, something like that. But get whatever vital signs you would like to get as many as you can, but the big ones that we have to get are blood pressure, heart rate, and respiratory rates. And we reassess those every 5 minutes. Remember, every 5 minutes for critical patients, we get another set of vital signs. So now we'll go ahead and move into our secondary assessment. Now, the secondary assessment takes place once any and all threats to airway, breathing, and circulation have already been assessed and have been managed as needed. The goal here is to check the patient head to toe for any injuries that we haven't yet identified. We want to find every injury, every abnormality, every problem that patient has. If we do happen to find any life-threatening injuries that weren't addressed or identified in the primary assessment, we're going to want to treat those immediately. Any airway, breathing, circulation problem, those ABCs are always the priority, right? If we find any threat to the patient's life, any problem with their airway or breathing or circulation, those injuries are going to take priority. A lot of the things that we're going to cover really come down to wound care, right? Splinting an extremity fracture does not save the patient's life. We need to do it if we can, if we have time, because that will reduce their injuries, that will reduce their pain, and it is good medicine. But we never want to get distracted. We never want to get so absorbed in wound care that we fail to identify or to treat a life-threatening problem. So we'll start with a quick mnemonic that a lot of folks find very useful, which is DCAP BTLS. These are the things that we're looking for when we go head to toe. We are going to look at everything, touch everything, and identify our DCAP BTLS type of problems. Stands for deformities, contusions or crepitus, abrasions, punctures or penetrations, burns, tenderness, lacerations, and swelling. There's a few different iterations of this mnemonic, but you see the same words, the same problems listed there. Deformities are pretty intuitive. Contusions just refers really to bruising. Crepitus is kind of a crunching that we get if we palpate a fracture, if we see bones moving when they shouldn't. Abrasions are pretty intuitive. Punctures or penetrations, which are holes that aren't supposed to be there. Burns. Tenderness is where we palpate and the patient experiences pain when we manipulate an injury or palpate an injury. Lacerations are little cuts, and then swelling is pretty intuitive there as well. But these are the problems that we are looking for when we go head to toe. It's a pretty useful mnemonic, but we're going to cover the specific injuries that we might find. So we're going to go ahead and go through every line item, every check that we need to hit in our trauma assessment skill sheet, and we're going to go over some of the injuries that we might find along the way. So we will start with our head. The skill sheet says to assess mouth, nose, and face, to assess scalp and ears, and to assess eyes and pupils. We want to take a look in the patient's mouth, find anything that might cause an airway obstruction, and find any trauma to the mouth. We want to take a look at the nose and the face. We want to visually inspect. We want to see if we find any injuries, see any drainage from the nose especially, and we want to palpate within reason. We don't want to palpate so aggressively that we might push bone fragments into the patient's brain, but we want to identify any obvious deformities, any obvious injuries, any of those decap BTLS problems that we talked about. Take a look at the scalp and ears. Once again, visually inspect and palpate. Take a look at those ears, see if there's any drainage of blood or cerebrospinal fluid or both. Then take a look at the patient's eyes and specifically their pupils. What we want to find is pupils that are equal, round, and reactive to lights. The terminology there is PEARL, which stands for pupils equal, round, and reactive to light. This is a really important assessment when it comes to neurologic outcomes and neurological injuries. Brain trauma, serious brain injuries will result in pupil problems, right? You will find one pupil that is blown, so they are not equal. You will find other problems accordingly. So pupils should be equal size, they should be round, and they should react to light. So when you shine a light in pupils, they should constrict, and they should both constrict simultaneously. If you shine a light in the left eye, the right one should constrict right along with it. They should always be equal. Paramedic proctors, EMS proctors in general, are notorious for finding the one person in the area who maybe has a false eye or has something going wrong where their pupils are not PEARL at baseline to try to trick you and catch you. So make sure you are forming good habits. You don't just get in the habit of opening up the mannequin's eyeballs and saying their pupils are PEARL. Make sure we are actually assessing to find that they are equal, round, and reactive to lights, or if they are not, we document accordingly. So we'll talk about some of the injuries we might find when we assess our patient's head. The first set of injuries is going to be skull fractures. There's a few different types of skull fractures out there. The first we'll cover is a linear skull fracture. This is a pretty minor fracture, right? It's just a crack in a skull bone that does not actually move any bone. Nothing is displaced, and the underlying brain tissue usually isn't that damaged. Interventions in these aren't usually necessary. The patients just require some careful monitoring. They absolutely need to go to the ER. Obviously, we can't diagnose the type of skull fracture, but we want to understand what this means, right? A linear skull fracture, usually pretty minor. Interventions are pretty minimal, and patients usually have pretty good outcomes. The next is a diastatic skull fracture, and this is when we have a fracture along one of those existing suture lines. Remember, your skull is composed of several different bones that are firmly fused together along these suture lines. When one of those breaks and splits open, we call that a diastatic fracture. These are most common in newborns and infants, where those suture lines haven't formed completely. Infants will have soft spots on their heads normally because their skull is still forming, and so they are predisposed to these diastatic fractures. These are a little bit more concerning. Sometimes they are okay. Sometimes they require minimal intervention, but sometimes they are life-threatening because the brain can herniate, it can protrude through the new opening when a suture line breaks. We can cover depressed skull fractures here. That just simply refers to the nature of the fracture. It means there is a deformity. A portion of the skull is sunken in, which means there's a piece of skull bone or several pieces of skull bone that are pushed inward towards the brain. And this is obviously a very bad day for the patient because it means their bone is pushing a direct pressure on their brain and potentially causing a traumatic brain injury. This can result in a leak of cerebrospinal fluid from the nose or ears or somewhere else. An open skull fracture, just like any other type of open fracture, comes with protruding bone fragments. So bone will actually stick out through the skin, and with this we will usually have exposed brain matter as well, and that's not a good day for the patient. That's going to make them susceptible to infections, and trauma that's bad enough to open up the skull is going to cause other life-threatening injuries, and traumatic brain injuries are very common when we have open skull fractures, are very likely to have occurred. Next is a basilar or basilar skull fracture, however you prefer to pronounce it, and hence the terminology here. It involves a fracture on the base of the skull, on the underside of the skull, which is nearby a lot of really delicate real estate, right? We have our brainstem there. We have a lot of very important structures that can be damaged when we get a fracture on the base of the skull, and it takes a ton of trauma to actually fracture the base of the skull because you don't usually get a direct impact to the underside of the skull here. So these are the most serious type of skull fractures. We can't ever diagnose in the field, right? This requires a CT scan, some x-rays, invasive imaging of some sort to identify the fracture type conclusively, but we do have some very highly predictive symptoms that point us towards the likelihood of a basilar skull fracture or basilar skull fracture. One of those is any cerebrospinal fluid draining from the ears or nose. One of those is something we refer to as raccoon eyes or periorbital ecchymosis, that is discoloration that might look like bruising around the patient's eyes. It's called raccoon eyes because it makes the patient look almost like a raccoon. The other is the battle sign or Battle's sign, otherwise known as retroauricular ecchymosis. So those are really important areas to look. We always look at our patient's eyes. We always look at those ears and behind them for that sign of bruising, which indicates a basilar or basilar skull fracture. So next we'll go ahead and discuss Lefort pattern fractures, which are very complex fractures of the face. There are a few different Lefort pattern fractures that we'll cover. These are fractures that occur along existing lines of weakness in the skull. So weak areas where these recurring patterns of fractures tend to occur in response to some sort of major blow to the face. They only account for about 10 to 20% of skull fractures, so not every facial fracture is going to take a Lefort pattern, but these are patterns of fractures that we want to be aware of. Again, they're going to be the result of a major trauma to the face. It takes a lot of force, a lot of energy to cause these fracture lines, but we're going to go over them here. There are three main types of fracture patterns that are identified. Some textbooks will also cite a Lefort type 4 fracture, but we're going to cover the big three that are covered in pretty much any textbook that you read. These are life-threatening fractures, and they are severely disfiguring. Your patient's face will not look normal. It will be readily apparent that they have sustained some major facial trauma, and these patients are very likely to have other life-threatening injuries as well when you take into account the amount of trauma, the amount of force that is required to cause these fractures. The first one is a Lefort type 1. This is otherwise known as a transmaxillary fracture. This is a horizontal fracture that extends just below the nose. You see the fracture line in the photograph here. And it's the result of a very severe downward directed blow to the maxilla, which is a facial bone where the upper teeth connect, and it also includes a big portion of the upper roof of the patient's mouth. That is the maxilla, and we have a downward blow to that bone and essentially separation of that bone from the rest of the skull. So we have separation of the hard palate or the roof of the patient's mouth from the rest of the face, and a Lefort type 1 fracture. Photo's worth 1,000 words every time. You can see the fracture line right there. Next is a Lefort type 2. This is a pyramidal shaped fracture of the midface. The fracture in this case starts at the bridge of the nose between the patient's eyes, and it extends downward and along the hard palate once again. So the result here is a pyramid-shaped piece of bone that is now separated from the rest of the skull. The separation of bone is why these fracture patterns are so disfiguring, right? You have a big portion of face that is no longer attached to the skull like it should be. In a type 3, the fracture line moves up once again. This is otherwise known as cranial facial separation. In this case, the vast majority of the patient's face has separated from the rest of the skull. These are the most disfiguring types of Lefort pattern fractures. In this case, the fracture once again begins at the bridge of the nose, but it extends, instead of going downward like a Lefort type 2, it extends backward across the eye sockets or the orbits. And so the separation, this piece of bone that is separated, does include the cheekbones or the zygomatic arches. This is the result of a very severe blow to the nasal bridge that leads to this fracture line kind of going straight back and separation of the majority of the patient's face from the rest of the skull. So moving down to the neck, the skill sheet says to assess the cervical spine and to assess for tracheal deviation and jugular vein distension. When we assess the cervical or C-spine, we want to gently palpate down each vertebrae, feeling for any deformities. We want to make sure we aren't using any excessive pressure. We don't want to push any bone fragments into the spinal cord that would cause more problems than the patient already had, but we want to identify any deformity, and we want to identify if there's any tenderness, if the patient experiences pain when we palpate down their neck, which is going to increase our suspicion of cervical spine injuries. We then assess for tracheal deviation. We want to make sure the trachea is midline where it should be, and we want to look for distended or swollen neck veins or jugular vein distension. So any injury to the cervical spine is considered life-threatening because high spinal cord injuries are life-threatening. The phrenic nerve, this is a good piece of background knowledge to understand. The phrenic nerve originates from spinal nerves C3 through C5, and this provides ventilatory control. This is a nerve that allows us to breathe. If we have a spinal cord injury above that level, we lose our ability to breathe, and that is why a patient will die because they will be unable to breathe. So you can remember the phrase C345 keeps you alive, or C5 keeps the diaphragm alive. There's a lot of kind of similar mnemonic devices out there, just as memory aids to remember that the phrenic nerve originates from spinal nerves C3 through C5, and so any high spinal cord injury can take away a patient's ability to breathe. It is impossible to rule out C-spine injuries in the field. We can assess, we can have a suspicion of a cervical spine injury, but we never know definitively. The patient is going to need a CT scan, they're going to need x-rays, other invasive imaging to identify cervical spine injuries. We are there to presume whether or not they have a C-spine injury, and we want to err on the side of caution. Any deformity, any tenderness, we want to presume that there is an injury there and be as careful as we can with our patient's spine. So we'll cover C-collars here. C-collars are a very commonly employed tool in EMS that are designed to limit motion of the cervical spine. The goal of a C-collar is really to remind the patient not to move their head or neck. The word immobilize, when we use it in EMS, is usually a misnomer because even with a perfectly applied cervical collar, a patient can still manipulate their neck if they want to. They can still exacerbate cervical spine injuries. What we're doing is putting a collar there to remind the patient not to move their head or neck and just to reduce motion of the cervical spine. In most cases, manual stabilization is still required even with a C-collar. Notice in the photo here how someone is holding this patient's neck even though they are wearing a C-collar. That's because a C-collar doesn't actually immobilize the head or the neck, right? Until a patient is fully secured to a long backboard, we've got to maintain manual stabilization of the C-spine whenever we reasonably can. So the basic procedure to employing a C-collar is number one, we have a partner employ manual stabilization right away while we are applying the collar and before we apply the collar. We're going to measure the height of our C-collar between the patient's jaw and their shoulder. There are a lot of different techniques to do this. You'll be shown a variety, I'm sure. Most people will measure based on finger widths. They will see if there are 3 or 4 finger widths between the patient's jaw and their shoulder, and then we adjust the height of the cervical collar according to the particular product that we have. The different cervical collars will have a different method of adjusting the heights. We then apply the cervical collar from the front. We make sure we secure the patient's chin there and very carefully secure it around the neck. We want to make sure that we don't cause any lateral or twisting motion of the cervical spine. We want that patient's head and neck maintained in that neutral position that our partner is hopefully holding, and very gently apply that cervical collar and get it wrapped around their neck. We want to make sure with any of these interventions that we are not manipulating the neck, that the neck is going to stay still, our partner is going to hold it in one position. There are a lot of potential adverse effects of cervical collar use that are going to be more frequent if we poorly apply the cervical collar, if we don't use the proper sizing or we don't apply it in a safe manner. One of those is that it complicates airway management. This is arguably the most important complication here because it makes it very difficult to manipulate. Obviously, the goal is to prevent manipulation of the spine, of the cervical spine, and rolling the head back is a very useful tool in airway alignment, right? When we're doing airway management. And so you might end up having a decision to make of what your priority should be, but we want to make sure we are not manipulating that C-spine. So it makes airway management quite a bit more complicated, makes things like intubation a whole lot more difficult as well. We can also cause a pressure on the patient's neck veins that prevents blood from draining out of their head back into their heart, and that can increase intracranial pressure and can make some traumatic brain injuries worse. And that's going to be a lot more common if we put the collar on way too tight, right? We want to make sure it's not so tight that it's compressing their neck veins. We can also cause a vagal response, or kind of a rest and digest response that's going to lower the patient's heart rate if we put pressure on their carotid arteries. That is just a natural reflex that the body has when we get pressure on the carotid arteries, and that's another potential complication. We can also get undesired lateral flexion or hyperextension of the neck if we use an improperly sized collar or we don't use good form when we are applying it. If we inadvertently cause manipulation of their neck, that's why we have to be very, very careful when we apply these. Complications are a lot more likely to occur with poor placement. This is a skill to practice with every single person in your EMT class, with every person you can convince to allow you to put a C-collar on, so you get good practice, get good habits of sizing C-collars appropriately and putting them on in a safe manner, because we don't want to do any more harm than good. The end goal with cervical collar use is simply to remind the patient not to move their head or neck and to hopefully reduce some of the motion of the cervical spine. Moving down into the chest here, the skill sheet says to inspect, palpate, and auscultate. When we inspect the chest, we first have to expose it. We have to remove any clothing. We want to make sure we take steps to prevent heat loss. We don't want to leave the patient exposed for long, but we want to visually inspect the chest. We want to look for visible injuries. Then we're going to go ahead and palpate. We're going to feel the patient's chest. We're going to feel for any chest wall instability. We're going to feel if there's any bones that are moving that shouldn't be moving. And it's great form to go ahead and feel the chest while the patient breathes. Whether they're breathing spontaneously or a partner is breathing for them, we want to feel that chest wall movement during the patient's breathing so we can see how well their chest is working. And then, of course, we will auscultate. Now, auscultating, listening for lung sounds in a trauma patient is a little bit different than listening for lung sounds in a respiratory patient. A lot of the times we just care if they have lung sounds on both sides. That's getting out of the realm of musculoskeletal injuries, but we don't always listen for lung sounds as in-depth in trauma patients as we do in a respiratory emergency, for example. So there's a lot of injuries that we might find in a patient's chest, right? We might find bleeding, we might find rib fractures. We can't definitively identify a rib fracture, but we can identify deformity or a lot of pain that increases our suspicion of a rib fracture or a rib injury. We can find bruising. We might find a flail chest, which is a specific injury we will discuss shortly here. We might find a pneumo or a hemothorax, again, out of the realm of musculoskeletal injuries, but it is an injury we want to identify when we look at a patient's chest and assess them. We might identify a cardiac tamponade, a very specific injury pattern. But understand we have very limited diagnostic ability in the field, right? We can find DCAT BTLS, we can find deformities and contusions, crepitus, we can find things that we see, but we can't diagnose any specific problem. We might increase our suspicion that the patient has a certain problem, but we have limited ability to actually diagnose problems in the field. We are there to assess and manage appropriately. So we will discuss flail chest specifically here. This occurs when we have a detached section of chest wall. This generally requires that we break at least 3 ribs in at least 2 different places on each rib. The result here is a detached section of chest that will actually cave inward when the patient breathes, right? Whereas the rest of the chest will be expanding during inhalation, the detached section of chest wall will cave inward and make ventilation a little bit more difficult to the patient. A flail chest typically comes with underlying lung injury as well, because it takes a ton of trauma to break that many ribs. What we look for is what we call paradoxical motion, which is that opposite motion, right? It's where the chest moves one way, the flail segment moves the opposite way, moves opposite to the rest of the chest wall. Any instability of the chest wall should arouse suspicion of a flail segment. We'll talk about trauma criteria later, trauma triage later, but any chest wall instability should make us think that the patient may have a flail chest injury. So treatment of a flail chest is a bit dynamic. It is actively changing. In the old days, they advocated for padding and actually splinting of the chest, but the research has come out and kind of shown that flail chest in and of itself isn't really a life-threatening injury. It just tends to accompany other life-threatening injuries. Patients with flail chest have a pretty high mortality rates, but that's because it takes an enormous amount of force to break this many ribs, to detach a section of chest wall. So these patients usually have an underlying contusion. They have bruising of their lung tissue that complicates airway and gas exchange. And so these patients tend to have other life-threatening injuries is the bottom line here. If needed, positive pressure ventilation will help this patient move air. If they aren't able to ventilate adequately with their flail segment, we can breathe for them. Some protocols will still recommend the use of a bulky dressing or some sort of splint to the injury, but those are not national standard of care anymore, right? Standard of care now is to notice the injury and to support the patient's ventilation. We don't actually have to do anything specific to the flail chest other than maybe some padding for patient comfort. Again, flail chest alone is very seldom life-threatening, but it typically accompanies other life-threatening injuries. And larger segments are going to be worse, are going to have more problematic effects on your patient than smaller segments. We'll move down to the abdomen. This is outside of the realm of musculoskeletal injuries, but just covering the trauma skill sheet, we'll briefly cover it. The skill sheet says to inspect and palpate the abdomen. We want to feel all 4 quadrants. We want to look for any visible bruising. We want to feel for any rigidity or guarding or deformity, anything like that. And we want to assess for any abdominal pain or abdominal tenderness. Again, this is outside the realm of musculoskeletal injuries, but it is in the trauma skill sheet. Moving down towards the pelvis. This is a really important area of assessments that unfortunately a lot of EMS providers kind of gloss over and don't necessarily do properly. And we don't necessarily deliver good care to our patients if we gloss over this area. The pelvis is a ring-shaped structure that's composed of 3 individual bones. Those are the ilium. It's very commonly confused with a very similar word that refers to a portion of the small intestine. Notice the difference in spelling here of the ilium. Ilium refers to a bone of the pelvis. Then we have the ischium and the pubis or the pubic bone. Your pelvis connects with your sacrum to form a complete ring, which links it in with the patient's spinal column. There are a lot of organs within that pelvis. It does offer a little bit of protection of some of the organs, especially reproductive organs, and some major blood vessels in there around the pelvis. And it is a major structural element of the skeleton. A very, very big bone that bleeds a lot when it gets injured. So we're going to talk about pelvic fractures here. Very important fracture, very important injury to identify with very important treatment goals here. The pelvis is a very large bone like we looked at, right? Big potential for life-threatening blood loss. A patient can actually lose their entire blood volume into the body cavity around the pelvis. So this is a life-threatening problem, right? Any pelvic fracture is immediately life-threatening. The mortality rates for pelvic fractures, all in all, is between 7 and 19%. Major fractures are obviously going to have a higher mortality rates than minor fractures are. Vehicle collisions are going to be the most common cause, but any major trauma to the pelvic region can lead to a pelvic fracture or several pelvic fractures. Aggressive assessment of the pelvis can be dangerous. In the old days, they were very big on pushing down on the pelvis, maybe even rocking it to try to see if there's any deformity, and that's really no longer recommended. We want to be very gentle when we assess the pelvis because we can make these injuries a lot worse. We can drive a shard of bone into a major blood vessel and cause an injury to the patient that wasn't already there. So we want to be very gentle, right? If we bear down on the pelvis at all, if we find any deformity, any movement that shouldn't happen, we want to immediately stop and assume there is a pelvic fracture. But even that really isn't recommended, right? So we have very limited diagnostic ability in the field once again here. And most of the research is saying that we should just presume there is a pelvic fracture when there is enough trauma to cause a pelvic fracture, right? Any pain when we palpate the pelvis, we want to presume the patient might have an injury. So when we're assessing, we assess for bruising, deformity, or swelling in and around the pelvis or the groin region. You can lose a lot of blood in and around the pelvis, so any swelling in that area should arouse suspicion that that blood is coming from the pelvis or a major blood vessel around the pelvis. Any swelling of the perineum or the scrotum can indicate swelling from a pelvic injury, either blood loss or soft tissue swelling. We want to assess for pain in the pelvis, the lower back, the groin, and the hips, where patients might feel pain in response to a pelvic injury. Want to compare the length of the lower extremities. If one extremity is shorter than the other, that can indicate anything from a femur fracture all the way up to a pelvic fracture affecting the hip joint there. So comparing the length of the lower extremities is actually a really important thing to look for in our trauma patients for suspicion of some of these major injuries here. Most of the research, like I said, is saying that we should presume a pelvic fracture is there when major trauma is present. The risk of treating a pelvic fracture when there isn't one is very low. The risk of missing a pelvic fracture, the risk to the patient when we miss a pelvic fracture is very high, very likely to lead to mortality. So treatment is aimed at reducing the capacity for blood loss. We want to limit the amount of space in this region where blood can be lost and no longer be in the patient's blood vessels where we need it to be. Once again, a patient can lose their entire blood volume into the space around a broken pelvis, which is a bad day, very fatal potential here. Further movements of bone fragments can also lead to other soft tissue injury. A shard of bone can absolutely puncture a major blood vessel and lead to more bleeding, right? So any manipulation of a broken pelvis is going to cause more soft tissue injury. That's why we want to be very, very gentle, even when we're assessing. Even when we're assessing for a pelvic fracture, we want to be gentle here. Research says that pelvic stabilization should be routine when an injury is possible. Once again, the risk of applying pelvic stabilization when there isn't a pelvic fracture is very low. That's unlikely to cause harm to a patient, but a lot of harm can come from failing to identify this injury and appropriately treat it. So field management of a pelvic fracture is actually pretty straightforward. It really just comes down to putting something around the pelvis to try to keep everything together. When the pelvis breaks, it usually or oftentimes will actually shatter. It doesn't just fracture like a normal bone. It tends to break into a bunch of little tiny pieces that can then go and cause other damage. And our treatment goal is really to hold everything together. So commercial devices are really the way to go when they are available. Not every EMS agency is going to have them, but when they are available, we want to use them. There are a lot of different commercial devices out there, and you apply according to the manufacturer's instructions. But what most of these devices are is just a sling. It's kind of a belt-like device that is going to go around the patient's pelvis and apply pressure to hold everything together. When we don't have one of those, we can take a sheet and we can simply wrap it around the patient's pelvis as tight as we reasonably can, and then we can actually add internal rotation of the legs to further reduce the volume available for blood loss in the pelvis. Commercial devices are ideal. The research behind them shows that they are very effective at reducing blood loss and pelvic injuries, but if we don't have them, we just kind of go with the old school treatment of wrapping a sheet around the patient's pelvis nice and tight. Another thing to consider when it comes to these is when we remove clothing that might be holding a pelvis together, right? You may very well consider just leaving something that might be a belt or something that would be binding a pelvis together, leaving that in place just around the pelvis alone. We have to remove clothing enough to assess for injuries, but that is a consideration. We can find, and there are cases of patients deteriorating when we remove clothing that was restricting motion of the pelvis. All right, so we'll move down into our extremities now. First thing I want to say is try to avoid assessing upper extremities before the chest, abdomen, and pelvis. You're a lot more likely to find life-threatening injuries to the chest, abdomen, or pelvis than you are to find life-threatening injuries assessing an extremity. Extremity fractures, while they are painful, while they are something we treat if we have the time and resources to do so, they aren't usually life-threatening, and so we want to address them later on in our secondary assessment after we have looked at areas that are more likely to uncover life-threatening injuries. So when we go down on our head to toe, we kind of skip over the arms at first, but remember to go back up to your upper arms, up to your upper extremities, after you have assessed everything else. When it comes to extremities, the skill sheet says to visually inspect, palpate, and assess CMS. So we have to make sure we expose the extremity to look for visible injuries, look for visible bruising, deformity, anything like that. And then we feel the extremity once again within a reason. We don't want to cause additional damage. We don't want to cause unnecessary pain to the patient, but we want to feel up and down their extremities to make sure we don't find any deformities or otherwise signs of an injury. Then we assess CMS. That's very important. That's something a lot of folks forget to do. It is something that is usually done beforehand while we put the patient on a backboard. We'll discuss that later. But CMS stands for circulation, motor, and sensory, right? When we're assessing circulation, we're looking for distal pulses, radial pulses, and pedal pulses, and capillary refill time to assess circulation distal to whatever deformity, whatever injury we have found. When it comes to motor, we want to make sure the patient can wiggle their fingers, wiggle their toes, and do whatever motions we want to ask them to do. And then when it comes to sensation, we want to make sure the patient can feel. Touch a toe, ask them what toe you're touching. That way you are confident that they aren't just in psychological denial, that they have numbness, that you know they can feel you touching their extremities. So touch their toes, touch their fingers, make sure they can tell you where you're touching them. So we'll touch on fractures specifically here. That's one of the main injuries we might find when we're assessing extremities. We'll divide these, we'll talk about a little bit of terminology and talk about some specific fracture presentations. We'll start with open versus closed. An open or compound fracture involves a break in the skin and bone sticking out. If you see a fracture with a bone end sticking out of the skin, that is known as an open or a compound fracture. Infection control becomes a big factor in those. We want to make sure we keep them clean. Closed fractures, on the other hand, involve intact skin. The bone might be shattered into a million pieces, but it is staying inside. There's no break in the skin. There's no bone fragments protruding through the skin. Displaced fractures occur when bone breaks and the ends will move from their position. That's what you see in the photograph here. You see there's an obvious break in those long bones and they have moved out of alignment. That is known as a displaced fracture versus a non-displaced fracture where the bone will break in some way, but the bones will stay in their normal alignment. They won't move even though they are broken. So we'll talk about a couple specific fracture presentations, starting with green stick fractures, which are partial fractures that most often occur in children who don't have fully developed bones yet, right? So green stick referring to trying to break a green stick that just kind of bends out of place instead of completely shattering, if that makes sense to you. A transverse fracture occurs perpendicular to the bone's axis. So in this photograph here, the upper bone, you see how that fracture is perpendicular to the axis of the bone. That's called a transverse fracture. A linear fracture would be opposite. A linear fracture occurs parallel to the bone surface. I don't have a photograph of that one, but you can imagine what that would look like, right? In line with the axis of the long bone. An oblique fracture occurs at some sort of diagonal or sloped direction. So the lower bone in the photograph here, notice how that's a kind of a diagonal fracture line. That's known as an oblique fracture. And then a comminuted fracture occurs when a bone breaks into a bunch of different pieces. That's very common in pelvic injuries. They do tend to shatter, but if a bone breaks into a bunch of little shards, a bunch of little pieces, that's a comminuted fracture. A spiral fracture is going to be the result of a twisting motion of a bone. If we twist a bone to its breaking point, that will lead to a specific injury called a spiral fracture. Avulsion fractures occur when a piece of bone is separated from the rest of its mass. That basically means we have a chunk of bone that has been blown away from the rest of it, right? A little chunk of bone moved out of position is an avulsion fracture. A buckled fracture occurs when bone ends get driven into each other. So see the photograph here, if you imagine those bone ends getting shoved into each other, that is called a buckle fracture when the bone just crushes against itself. Stress fractures occur either typically hairline cracks, right? Hairline fractures, they'll otherwise be called, that occur in a bone usually when it's overstressed, hence the term stress fractures. Most of those aren't going to be displaced. They're going to be very minor fractures there. Finally, we have pathologic fractures, which is any type of fracture that occurs because of some sort of disease that weakens bone. So a lot of elderly folks will have brittle bones. They will have problems with their bone in general. If those pathologies, if those bone diseases lead to fractures, we call those pathologic fractures. Another potential type of injury is a dislocation. And a dislocation, bones are displaced from their normal position within a joint, right? Shoulders, elbows, any joints, if the bones move out of their alignment that they're supposed to be in, we call that a dislocation. We can't definitively diagnose a dislocation in the field. Patients do need x-rays, but it's one of those where we can have a strong suspicion. Certain types of dislocations might be reduced in the field by properly trained providers. A good example is a lateral patella dislocation. If a patient's kneecap has displaced off to the side of a patient, that is a common one that we are able to reduce in the field, but that's always in accordance with your own local protocols and the training that you actually have. It's very difficult to assess for fractures in the field. We don't know if there is a fracture involved in that joint, if it is just displaced out of its alignment. And so we don't generally do a lot of manipulation on these, right? Field reduction of these is pretty rare. We typically leave these in place. We immobilize just like we would a fracture, and we get them into an emergency room to assess them for further injuries and develop a plan of care for them. So we treat them with immobilization and pain control within our scope. Let's talk about assessing extremity fractures. Number one comes with visually inspecting the bone involved. We want to look for signs and symptoms like bruising or swelling, and then any obvious deformity or angulation that shouldn't be there. If a patient's bone that is supposed to be straight is angled, there's probably a fracture or something going wrong with it. When we palpate, we're looking for tenderness, seeing if the patient is experiencing pain. We don't want to force that. If it's hurting the patient, we want to be as gentle as we can. And then we're feeling for deformities. And then another good test to throw in when we're dealing with extremity stuff is a range of motion test. See if the patient can move their extremities like they normally can. If they aren't able to do so, that indicates a potential for an injury. When it comes to managing extremity fractures, once again, I will really lay in that life-threatening conditions need to be managed first. Extremity fractures aren't life-threatening. Our management of them doesn't usually save the patient's life. So if there are life threats to be treated, give priority to those life threats. And wound care is something that can occur en route. We can splint extremity fractures en route to the hospital if we need to take a patient to a hospital quickly, which we do for a lot of trauma patients. We use splints for long bone and joint deformities. So we say deformity because we don't always know if it's a fracture or a dislocation. If there's a deformity, an injury that needs to be immobilized, we use splints. We will talk about our splinting procedure. And then pain control within your scope of practice, right? Even as an EMT, ice packs are a great move. It's something we can oftentimes forget about, but ice packs do a great job in a lot of patients. Position of comfort. So keeping a patient comfortable, making sure that extremity isn't bent in a weird direction, just keeping them in a comfortable position where weight is off of any injured extremities and things like that. And then immobilization is a skill that actually relieves pain over time. It usually hurts quite a bit while we're doing it, right? The better we are at splinting, the less it's going to hurt the patient, but it's something where they kind of have to invest a little bit of pain, so to speak, right? They're going to incur a little bit of pain while we splint an extremity, but over time, as that extremity is immobilized and no longer moving, no longer causing secondary tissue damage, the patient will start to feel better over time. That's just something to communicate with your patient, that the splinting process is not going to be very fun, but it's going to make them feel better over a few hours or even a few minutes in some cases. Another potential recommendation you might get is to elevate an injured extremity. This isn't there to reduce hemorrhage or treat for shock or anything like that. It's just there to reduce a little bit of extremity swelling. We can achieve that with ice packs as well, but if it's appropriate in a situation, you might consider elevation of extremities that are injured. So now we will talk about splinting. This is a very critical skill in EMS, right? This is a very commonly failed skill, unfortunately, because there's a lot of really important steps. Even if it seems really simple, it is a commonly failed skill that we want to spend a little bit of time practicing. The goal of splinting is to immobilize broken or injured bones or otherwise restrict their motion so that we don't have secondary tissue damage getting done. It's going to provide relief from pain over a period of time, once again, and it reduces the possibility of secondary soft tissue injuries. So anytime we have an extremity fracture, we have bone shards, ends of bone that are digging into soft tissues. That causes a lot of pain and it causes a lot of secondary soft tissue damage. When we immobilize broken extremities or injured extremities, we reduce that capacity for secondary injury. So it does do good for our patients. Just remember, it's probably not saving their life. Application of splints is often excruciating. Like I said, it's kind of an investment. Patients incur a little bit of pain right away, but it makes them feel better over time. And when we're using splints, we want to try to remember to add padding to any bony prominences to reduce discomfort. If we put a rigid splint right up against a deformed piece of bone, it's probably going to be uncomfortable for the patient, especially those of you who might be, you might have a prolonged transport time. It might take 30 minutes to get them into an emergency room. We want to take as many steps as we can to keep them comfortable. Let's go ahead and talk about our skill sheet for a long bone splint. First up on any sheet is going to be PPE BSI, right? BSI is my scene safe. Manual stabilization of the injury is something that should happen early on, so you want to hold any injuries above and below wherever the deformity is. If you have an angulation to a patient's forearm, you hold it above and below that angulation to try to keep it held in place. Manual stabilization is your first step, and then we move into a CMS check. Remember, anything extremity related, we're going to assess circulation, motor, and sensory. Select your splinting material. There are a lot of splinting options out there these days. We have vacuum splints, air splints, we have malleable splints like your SAM splints, we have cardboard or improvised splints. There are a lot of different devices out there. Just know whatever products you are going to be using, understand how to work them so that you know how to work them when the time comes to actually put them on a real patient. A splint properly applied should always immobilize a joint above and below an injury. When we're talking about a long bone deformity, something mid-shaft, we're at a presumed fracture, we want to splint in a way that immobilizes, prevents motion of the joint above and below the injury, because if those joints move, it's going to manipulate the bone that is potentially injured here. So for example, a tib-fib fracture, right, a lower leg fracture, we're going to make sure our splint immobilizes the patient's ankle and their knee. We always immobilize any position of function. We don't want to hold patients' extremities in a completely angulated and awkward position unless it is stuck in that position from the injury. We want to try to immobilize in a position of function. If we're splinting a tib-fib fracture, for example, we want to keep the foot in a natural position. We don't want the foot bent off in some weird shape and weird direction that's going to be very uncomfortable for the patient. So position of function is a big portion when it comes to long bone or joint splinting. Make sure we secure the entire extremity. So that comes, sometimes long backboards is a great tool to do that. Just getting the patient in the cot in a way that immobilizes the entire extremity so it's not going to be getting moved around or manipulated. And then always, 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 very easy to forget, but we have to reassess CMS. This is a critical fail on any skill sheet. If you forget to reassess it, we have to make sure we reassess CMS so that we know our splints, our interventions have not cut off circulation or sensation to that extremity. Next up, a very similar procedure, but in this case, we are immobilizing a joint instead of a bone, right? So in this case, maybe we have a deformity to a knee. We don't know if there's a fracture involved or a dislocation, but we're going to try to immobilize a knee. Once again, PPE BSI is the scene safe manual stabilization of the injury. Make sure you hold above and below any deformities. That is true for any extremity fracture, any extremity injury. Once again, right away, we assess CMS, circulation, motor, sensory. Once again, we select our splinting material, whatever is going to work in the given situation, whatever we are comfortable using, we're going to go ahead and break out our material. And in this case, when we talk about a long bone splint, we want to immobilize the joint above and below. In the case of a joint splint, we need to immobilize the bone above and below the injury. So in the case of a knee fracture, for example, we have to immobilize the thigh and the shin bone, the thigh and the lower leg. Then we secure the entire extremity once again, and always, always, always reassess CMS anytime splinting is involved. Good form to make sure we're just always doing that at the end for all of these skill sheets so that we don't forget, because we have to make sure our splint hasn't all of a sudden cut off circulation. We can talk about the different types of splinting material here. There are quite a few. There's air splints, vacuum splints. There are slings, which sometimes immobilize an extremity effectively. Malleable aluminum splints or SAM splints, cardboard, which is a great improvised way to make a splint, and then improvised splints in general. If you're a wilderness medic, you might end up making stick splints happen, right? You might use a random stick from the forest and make a splint with it. There's a lot of different types of splints. The bottom line is we have to practice with the equipment that we are going to be using. If you go out, you work for an EMS agency, it's very important to practice with the splinting material you have so that you know how to use them when the time comes. There are some potential complications of splinting, especially when we don't do it properly. The biggest one, the most apparent, is going to be aggravation of the injury. No matter how we put splints on, it usually hurts while we're doing it. Higher level providers can oftentimes administer analgesics, some pain management ahead of time to make it a little bit less uncomfortable. But the bottom line is that splinting is not always a very fun procedure for the patient, and it's going to hurt no matter how well we do it. We can cause compression of nerves and soft tissues. We can cause pressure sores. We can reduce perfusion of a certain portion of the extremity, especially if that splint's going to be on for a long period of time. We have to make sure we are careful and that we are very diligent about those CMS checks after we have applied a splint. There is the potential for reduction in circulation along with that. And then understand a really important one when we're talking about trauma care is the potential that we're getting distracted by an extremity fracture when there's something else to be done. We never want to delay transport in critical patients. We never want to get distracted away from an airway, breathing, or circulation problem. We want to make sure we, again, focus in on the life threats, manage extremity fractures, manage extremity injuries if and when we can. Sometimes these are isolated injuries. You'll go on someone who just broke their arm, and that's why they called 911. We can spend as much time as we need on those patients, but for patients pulled out of a mangled mess of a car, patients who are going code 3 to a trauma center, we don't want to get distracted from higher treatment priorities by worrying about extremity injuries. Let's go ahead and talk about femur fractures specifically here. A mid-shaft femur fracture is treated just a little bit different from other extremity injuries. The femur is a very big bone in the thigh. with a very high capacity for bleeding. Remember, bones bleed. The femur is a huge bone, and the femur will bleed a lot. You can lose a lot of blood volume into your thigh. Patients can actually lose a life-threatening quantity of blood from a mid-shaft femur fracture. Fracture of the femur, when it actually displaces the bones, is going to result in muscle contraction. Those muscles are going to be injured, and injured muscles tend to tense up. They tend to pull bones toward them. And so then these bone ends are getting driven towards each other, and those bone fragments will then dig further into soft tissues and cause a lot of really painful soft tissue damage, and also open up a lot of space for blood to leak out of those femurs. So there's a lot of reasons that this is problematic, and there's a reason that we treat it in the way that we do that we're going to discuss. So fatal blood loss can occur internally from a femur fracture. A lot of times these mid-shaft femur fractures, you will see the patient's thigh is completely swollen from soft tissue injury and from blood loss from the femur itself. So make sure we're taking these injuries seriously. These are potentially life-threatening injuries. We can assess for femur fractures here. Number one is looking at the mechanism of injury, right? Is there enough trauma here to break femurs? Motorcycle crashes, vehicle crashes, any serious trauma to the thighs is going to run the risk of a mid-shaft femur fracture or a femur fracture in general. Pain is a big one. If a patient is experiencing a ton of pain to their thigh, that's an indication that there might be an injury there. Swelling is another big one. Mid-shaft femur fractures, they tend to result in a lot of soft tissue swelling, and there's blood loss happening as well. So if the thigh is big and swollen, there's an indication of a femur fracture or a femur injury in general. Any obvious deformity or angulation makes it pretty easy to identify a problem. And then shortening of the thigh is another thing we look for. If the patient's left thigh is a whole lot shorter than their right, chances are there's an injury there, unless that happens to be normal for the patient. So that can also occur in pelvic and hip fractures. Shortening of the thigh isn't specific for femur fractures, but it definitely increases our index of suspicion of a problem with the femur or with the hip joint. So we treat mid-shaft femur fractures with a special type of splint called a traction splint. Traction really refers to pulling those bones back into alignment, making the thigh the same size as the other one back where it's supposed to be, to prevent those bones from getting pulled into the soft tissues of the thigh there. These are intended exclusively for isolated mid-shaft femur fractures. We do not use a traction splint. It is contraindicated if there are any other injuries. If there's deformity to the hips, if there's a pelvic injury, if there's a tib-fib fracture, we do not use traction splints. This is only for an isolated and mid-shaft femur fracture, meaning the fracture is in the middle of that long bone. The function here is the idea behind a traction splint is to pull outward on the leg to pull those bones back into their normal alignments. Once again, contraindicated anytime there is any other injury in that leg, right? The entire leg has to be fine except the isolated mid-shaft femur fracture that we suspect. The goal is, one, reduce hemorrhage. That's potentially something that will save the patient's life, which is rare for extremity fractures, but pulling those bones back into alignment reduces the capacity for blood loss and potentially reduces internal hemorrhage that's occurring there. And another big goal is going to be pain management, right? This is excruciating for patients when the bone ends are being dug into their muscle tissue. If we can pull them back into alignment, that secondary injury will stop, that secondary tissue damage will stop, and the patient should feel a reduction in their pain. But once again, it's probably going to hurt really, really bad when the patient is actually undergoing traction. But over the next few minutes, the patient should start to feel better. So we'll go over our procedure for a traction splint. Once again, PPE, BSI, make sure you ensure scene safety. Number one is manual traction or stabilization. If you have a partner available, you can have them apply manual traction. They can grab that patient's foot and pull on it. But anytime that is started, it can never be discontinued. If someone applies manual traction, they are committed to pulling that traction until you get a traction splint properly placed. If your equipment happens to malfunction, your partner is going to be stuck pulling on the patient's thigh for the duration of your patient encounter until they're in the emergency room. So keep that in mind. We can never discontinue traction once we have applied it, because that's going to risk a whole bunch of other injuries and actually make the patient worse than they were before. Always assess CMS, right? Make sure we We check pulses, make sure we check for motor function and sensation in that patient's foot. Apply the splint per the manufacturer. There are a lot of different types of traction splints out there. Everyone works a little bit different. We're typically going to apply cuffs to the patient's thigh and ankles, which are the points we're going to be pulling against. And we apply traction, which is usually about 10% of the patient's body weight. A 200-pound patient, we might consider up to 20 pounds of traction. Some protocols will put a max actually at 15. So let's say our patient is 150 pounds. We might apply 15 pounds of traction, 15 pounds of pulling force to pull those bones back into alignment. This is a skill that actually usually feels pretty good because it does improve circulation when there isn't an extremity fracture there. When you do this in scenarios, it does actually feel pretty pleasant to have a little bit of gentle traction applied, and you'll get experience doing that in your skills labs. Always, 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 when we talk about splinting and immobilization, check CMS when you're done, right? Make sure we didn't cause a problem that was not there to begin with. So last but not least, we assess our patient's back. This part of the assessment can be easy to forget. A lot of folks will go head to toe, but they will forget to roll the patient and check their back. It comes at the end of the skill sheet, and it's one we want to make sure we're not forgetting because it's a whole half of the patient's body essentially that is on their posterior. We want to make sure that we do this before a patient is on a long backboard as well. That is a skill we will talk about in a moment here, but if we're going to place a patient on a long backboard prior to transport, we need to assess the back when we are log rolling them onto a long backboard. Otherwise, we lose our opportunity to assess the back because we're not going to take a patient off of a backboard. Once they're on a backboard, they are there until they're in the emergency room in the care of a physician. So we got to make sure we don't lose that opportunity to assess the back. So when you're practicing your long backboard skill, try to form the habit of assessing the back anytime you log roll the patient so that we never forget to assess the back there. It's good to form good habits early on. We're going to inspect and palpate the posterior chest, inspect and palpate the lumbar spine and buttocks, and we're going to assess CMS if we have not done that already. So if you're doing this before you check extremities, we want to make sure we remember to check CMS because we're especially looking for motor and sensory deficits because those could indicate a potential spinal cord injury that will increase our suspicion of a potential injury there. We're never going to definitively know if a patient has a spine injury. That's going to require invasive imaging, so we always want to be cautious. We always want to have the suspicion of a spine injury and treat the patient accordingly, preventing any unwanted or unnecessary manipulation of their spine. We do the spine just like we do for the C-spine. We feel down each vertebrae. We're looking for any deformity or any tenderness. Just make sure you aren't using excessive pressure. We don't want to drive any bone fragments into the spinal cord because that would obviously make the patient worse than they were before. But we do need to identify any deformities that may be present. So we visually inspect, look for any bruising, anything like that. Palpate for any deformities, right? Looking for decap BTLS all the way down. Same thing goes with your lumbar spine and your lower back and your buttocks as well, or the patient's lumbar spine and buttocks. So let's go ahead and talk about the long backboard here. The long backboard is currently a very dynamic area of protocol change in EMS. There are some EMS organizations that no longer even carry long backboards. There are other EMS organizations that are very proactive, very aggressive in placing patients on a long backboard when we have even the faintest suspicion that they might have a back injury. Backboards have historically been used by default in any sort of major trauma with the thought process of reducing motion of the spine to prevent causing any spinal cord injuries or exacerbating or making spinal cord injuries any worse than they already are. A lot of protocols nowadays do not recommend the long backboard just as a default treatment in any trauma patient. They really only tend to recommend long backboards in patients where we have a suspicion of spine injury, so some physical exam findings that tell us a patient might have an injury, or when assessment is challenging. If there's a language barrier, an intoxicated patient, or a distracting injury that might prevent the patient from knowing or relaying the fact that they have a spine injury. Because typically when a spine injury is present in a conscious patient who can answer questions, they're going to experience pain. If a conscious patient does not experience any back pain, there's a very low chance that they actually have a spine injury. It's very important when it comes to areas of protocol change and dynamic EMS changes and arguably controversial topics. Very important that we follow our own local protocols and the guidance of our own medical direction and our local EMS system, right? Follow the local protocols in your area. Just understand that long backboard is still a skill, right? There's still a skill sheet for it, but you may very well end up with an EMS organization that doesn't even use these. We'll go ahead and go through the general procedure of using a long backboard. Always start with PPE, BSI, and scene safety, right? And we want to make sure we actually think about those things. We actually don our personal protective equipment and body substance isolation, and we actually look around to make sure we're in a safe spot, that we're not going to get hit by a vehicle, or we're not going to get into a violent encounter or anything like that. We're going to start with manual stabilization of the cervical spine. In scenario land, you have an imaginary partner do that. In real life, we want to make sure someone is actually doing that so that we don't forget about that, right? Have someone hold the C-spine in a neutral inline position, just like we talked about with C-collars. Someone needs to hold the patient's head and neck to prevent any motion, and especially to remind them not to move. We then start with checking CMS. We check for circulation, motor, and sensory, because we do consider the long backboard kind of like a splint. So just like when we talk about extremity fractures and splinting, we're going to check CMS before and after every time. After a CMS check, we're going to apply a cervical collar. Just like we talked about before, make sure we aren't causing unwanted manipulation of the neck. We place those on gently, make sure they aren't too tight and that they aren't causing unwanted effects, right? Make sure the patient can still breathe and that their head and neck are in a neutral position when we place those C-collars. And remember, those are mostly there to remind the patient not to move the head or neck. You still need manual cervical stabilization even once a C-collar is applied. Someone's hands need to stay on that patient's head or neck. We then position the board however we like it. You will learn this as a hands-on skill. You'll learn where you like to place the board to roll the patient onto it. Position the board where you want it, and then we always log roll the patient without causing any sort of manipulation of their spine. We don't want to cause any lateral motion. We don't want to cause any twisting of the spine. We want to log roll the patient in a way that minimizes the movement of any of the vertebrae in the spine and anything that might be in the way of the spinal cord. Bottom line is we want to be very gentle when we roll patients, because we don't want to cause exacerbation of any spine injuries, and we definitely don't want to cause any in patients who might have the potential for us to exacerbate those injuries. Anytime we're rolling a patient and someone is up at the head, they're the ones in control. Even if they aren't the ones leading the call, they're the ones who should be counting out and directing patient motion. So whoever's on the C-spine, whoever's holding the patient's head and neck in a neutral inline position, is the one who calls for everyone to roll. They'll say, on 3, we're going to roll towards my right. That is how we roll our patients. And you'll get a lot of practice at this during hands-on skill time. So once the patient is on that board, what we're going to do, we're going to log roll the patient, we're going to place the board under them, and then log roll them back onto the board. Once they are on there, remember that the spine is curved and that board is straight. So we're going to have some void spaces in most patients, and we want to consider using a little bit of padding, especially for prolonged transports. Put a rolled up sheet there, put a blanket, something to pad those voids and offer a little bit of lumbar support. A lot of you will be in areas that also carry what we call back rafts, which are air inflation devices. They're basically air mattresses that live deflated on the backboard, and once the patient is on them, we can inflate those devices that will automatically pad the void spaces in the patient's spine, and that allows a much more even distribution of pressure, because we can actually cause some injuries, very rarely, but we can cause some injuries with a backboard if there's certain parts of the back or certain parts of the spine that are pressed up against the board where all the pressure is on those certain parts, right? We'll talk about some of the complications, but using padding, using air devices really does reduce some of the unwanted complications of long backboard use. And especially if the patient's going to be on there for a while, we definitely want to take the time to use that whenever reasonable. We always secure the torso first. We never secure the head before the torso, because that can be dangerous. We secure the torso with the straps that we have. You'll get practice doing that, working on hands-on skills. The style of straps you see in the photograph we call spider straps. You might use those, or you might use a different style. Just depends on the equipment you're going to be using. We then want to apply some padding behind the head. Right? The head is going to be a little bit hyperextended backwards in your average patient, so we want to apply just a little bit of padding, a little bit of a pillow to keep the head in a neutral position. We're always looking for that slight sniffing position, at least some sort of natural position, right? We're not necessarily trying to manipulate them for airway management, but we want their head in a natural position where we're not going to cause injury or exacerbate injuries to their C-spine. So a lot of you will have equipment. You might have disposable head beds that will go on there with a pad that is designed to go under the head, and we want to do that. We want to keep the patient in a nice natural alignment, always maintaining neutral alignment to the patient's head and neck. After the torso is secured, we can go ahead and secure everything else. We'll typically start with the head. Once the head is secured onto the board, we can go ahead and discontinue manual stabilization, right? But until the patient has headbeds next to their ears, they need to maintain manual stabilization. They need someone's hands on there reminding them not to move their head or neck. But once we have headbeds, once the head is secured to the device according to the equipment we're using, we can go ahead and discontinue that manual stabilization. Then we're going to secure the patient's extremities. We're going to secure their entire body and do a once over of those straps to make sure they are tight. Paramedic preceptors are notorious. They will grab that board and they will try to put the patient on their side to see if they're actually well secured. Make sure they are on that board nice and tight. And then, as always with splinting type of devices, we check CMS when we are done. So we can talk about some of the potential complications of long backboard use. These are a lot of the reasons that some protocols are moving away from the aggressive use of long backboards. These do cause pain and a little bit of patient discomfort. I'm sure you will end up on a backboard going through EMS training, and you'll experience that they aren't necessarily the most comfortable devices in the world. If you have a 30-minute transport, your patient's going to be on there for at least 30 minutes and then maybe another 30 when they're in the emergency room. So they're going to be on there for a long time. Comfort is a big deal, and patient pain is a big deal for those. We can cause pressure sores. That's why we really advocate for padding of void spaces and using those air inflation devices if we have them. But we can have pressure sores if there's any kind of hot spots on the board, because remember, it's a curved spine being put on a straight board, so there are going to be areas where the pressure is a little bit higher, and we can get pressure sores, especially if patients are on that board for a long period of time. Along the same lines, we can have ischemia to certain body tissues, right? If circulation is cut off to an area of the patient's back where there's a lot of pressure on there, we can have some negative outcomes there. Respiratory compromise is a big one. We have to secure those straps nice and tight to make sure the patient isn't going to wiggle around, to make sure the board is actually doing something. But that can also make it hard to move the patient's chest, right? If their chest can't expand, they can't breathe adequately. So we need to take that into consideration. We need to make sure the patient is still able to breathe when they are on the board. And any sort of spine stabilization is going to complicate airway management. What we want to do is go up to that patient and do a head tilt chin lift, but that's not an option, right? A natural alignment or neutral alignment of the spine will make airway management easier, and that's what we should have, but it's always more difficult to manage an airway of a patient who's on a backboard. We can't move as many structures as we want to. There's not as much space available, so we take that into account. So that's a big complication, a big downside of the use of long backboards. Then another one is going to be agitation, especially if your patient is unhappy. Sometimes trauma patients will almost present as a behavioral emergency. They will not enjoy anything going on, and putting them on an uncomfortable board won't necessarily make them more calm. It can exacerbate some agitation. So we do have some other options. The NREMT is now defining the term spinal motion restriction, which is really just a more broad classification of anything that helps maintain an anatomical alignment of the spine and avoid gross manipulation of the spine. So if we log roll the patient and put them on anything, right, we can even place them flat on a cot. As long as the spine is in a natural and neutral alignment, we can reduce motion of the spine. So they're going towards the terminology of spinal motion restriction, which is a little bit more accurate, because anytime we use that word immobilize, it's usually a misnomer. If the patient really wants to, they can still wiggle their spine, they can still injure themselves, even if they're properly secured on a long backboard. So the NREMT is defining that spinal motion restriction term. It's a little bit more broad. It just refers to other things that we might use to reduce motion of the patient's spine other than an adjunct like a long backboard. When we use the term spine immobilization, that is referring strictly to the use of something like a long backboard. So when you see the word spine immobilization, it's typically referring to a long backboard. If you see the term spinal motion restriction, that can include any number of things, right? That can be placing a patient on a scoop style stretcher, can be placing the patient flat on a cot. However, we can go about reducing motion of the spine and keeping them in a nice neutral alignment, versus immobilization, which is a long backboard or a full body vacuum splint or something along those lines. We always want to avoid long backboards for prolonged transports. If we're going to be transporting the patient for more than about 30 minutes, we want to think about other options. You might have full body vacuum splints at your disposal. Those are great. Those really form to the patient's spine and all of their contours while still reducing their motion. Those are great tools that technically do count as spinal immobilization as well, so they are great. So we can talk about some other options. Again, this is very protocol specific, but you might have protocols that recommend a few different things instead of a long backboard. One of those is a full body vacuum splint. A lot of times we nickname those body burritos. You might get some hands-on time putting patients on those. Those are a lot more comfortable, especially for prolonged transports, and they do a pretty good job of restricting spinal motion and reducing exacerbation of spine injuries. Another one is a scoop style stretcher. Those are great, and those can be an option for spinal motion restriction, as can just placing a patient supine on a padded cot. If we're going for the more broad concept of spinal motion restriction, we have a lot more tools in our toolbox. We just want to make sure we are still log rolling the patient. We are not allowing unwanted manipulation of their spine. We should still use a cervical collar, right? Still think about complications of those. Make sure they are not too tight. Make sure the patient can breathe and swallow appropriately. But we should still be using a C-collar even when we're going for spinal motion restriction, even if we're not using a long backboard. The overall goal is to avoid manipulation of the spine, right? If we have a suspicion of spine injury, we want to avoid manipulating that spine in a way that can make that injury worse or can even cause a new injury. Again, this is a very dynamic area of change in emergency medicine. You will get guidance for your own local protocols, your own local area, and kind of the culture within a given EMS organization, whether or not you use long backboards a lot or if you use them very rarely. So now we'll go ahead and talk about a couple special patient populations, particularly pediatrics and geriatrics, just for a couple considerations for those age groups, and then we're getting to the end of the course here. So we'll start with pediatrics. The smaller size of a pediatric patient makes them a lot more prone to severe injuries in response to trauma, right? If they get the same amount of force applied to them, they're going to get more injured than their adult counterparts. Your treatment priorities are the same for pediatrics. It starts with the ABCs, or it starts with immediate life threats, moving on to your airway, breathing, circulation problems. We don't do anything different for pediatric patients, really. We just have a higher suspicion of severe injuries. And we like to teach that children compensate really well until they do not. Children will compensate, meaning they will have tachycardia, they'll have signs and symptoms of shock, but their blood pressure will be steady. They will compensate for a long time, but once kids' blood pressures start to go down, they go from doing just fine to cardiac arrest very quickly. So we have to have a high suspicion of injuries in kids. If they're showing any sign of shock whatsoever, we've got to get them to an emergency room because kids do tend to decompensate very quickly. And then always consider non-accidental trauma, right? That's the medical term for child abuse, just something we always need to screen for with our pediatric patients. Next is geriatrics, the other extreme age range, right? These are our elderly folks, and they're a lot more likely to have pre-existing medical conditions. So these folks are going to have long med lists, they're going to take a lot of medications, they're going to have medical history that is going to complicate their care when it comes to a traumatic event. A lot of them are going to take cardiac medications that will mask the signs and symptoms of shock. Medications like beta blockers and calcium channel blockers that are designed to keep their heart rate and blood pressure lower, right? So when we normally look for tachycardia as a sign or symptom of shock, we don't always see that because they might take a medication that blocks that from happening. It's a really important thing to keep in mind. Just because an elderly person isn't tachycardic does not mean they are not in clinical shock. They're also much more likely to die, and they tend to die a lot sooner than their younger counterparts, right? An equivalent traumatic event to an elderly person is going to be more severe just because they have that medical history and they are more fragile to begin with. Once again, our treatment priorities are the same. Prioritize life-threatening conditions, treat life-threatening bleeding and airway, breathing, and circulation problems, but do expect rapid deterioration of geriatric patients as well, right? Really focus on getting them to an emergency room because they are more fragile than their younger counterparts. So the last topic we will touch on here today is trauma triage. The Centers for Disease Control and Prevention, or the CDC, publish these trauma triage criteria using guidelines and recommendations that come from the American College of Surgeons, from the research that they have done and their own experience in treating trauma patients. These criteria are oftentimes used to determine which patients should be entered into a trauma system, which usually comes with a pre-hospital alert to let the hospital know you are coming in with a high acuity trauma patient so that they can divert resources and make sure they take care of that patient very quickly on their arrival in the emergency room. These criteria are also used in determining which patients need to be taken to a high-level trauma center and a high level of care versus which patients can be taken to, outlying community hospitals and lower levels of care. There's a really interesting and really helpful framework for that. In rural areas especially, taking a patient directly to a high-level trauma center oftentimes means bypassing the closest emergency room, which is a really critical decision that has to be made. You always want to follow your own local protocols and the guidance you get in your local EMS system, but these criteria are there to help us in making that decision. This is a 4-step triage process. Any patient who meets criteria in steps 1 or 2 should generally go to the highest level of care available within a region. If you have a level 1 trauma center, you should generally take those patients to that trauma center, or whatever the highest level of care available in your response area is. Patients who meet those criteria should generally go to that highest level of care available. Patients who meet lower steps, maybe steps 3 or 4 criteria, they should still go to a trauma center. They should oftentimes still be a trauma alert and an entry into the trauma system, but they might be taken to slightly lower levels of care, maybe a level 2 trauma center as opposed to a level 1. A lot of this is really EMS system specific, but these guidelines, these criteria are here to aid us in making that decision. The first step of this process involves assessing vital signs and level of consciousness. Your step 1 criteria are otherwise known as your physiological criteria. There's only 3 components here, really. We're looking for a blood pressure under 90 systolic or hypotension, a GCS below 14, otherwise stated as 13 or below, and a respiratory rate that is out of bounds, under 10 or over 29 for an adult, or under 29 for an infant, or if your patient needs any airway management or ventilatory support of any kind. We can't call their respiratory rate 12 if we're breathing for them, right? It has to be their own spontaneous respirations. So any patients who meet these criteria, if they have a low blood pressure, a low GCS, or bad respirations, or the need for airway or ventilatory support, we say they meet step 1 criteria, and we consider them the most critical class of trauma patients. Your step 2 criteria are otherwise known as your anatomical criteria. We're looking for injuries to certain areas of the body, quite a few injuries that we're looking for. We're looking for penetrating trauma, so gunshot wounds, stab wounds, anything of that nature, anywhere in the body other than distal extremities. So proximal to the elbow or the knee, any penetrating trauma to the head, neck, chest, torso, anything of that nature, or the upper arms or thighs is a step 2 criteria. It's always based on the worst finding. If any of these patients meet step 1 criteria, we consider them a step 1 patient. But if a patient does not meet step 1 criteria, we move on to step 2, and then steps 3 and 4 that we'll discuss as well. Also in the step 2 criteria are chest wall instability. Former iterations of this triage process labeled it as flail chest specifically, but the American College of Surgeons found that we don't always identify a flail chest, and so they changed the wording to just unstable chest wall. Any instability of a patient's chest wall is going to meet step 2 criteria. Next is 2 or more proximal long bone fractures. Proximal long bones include your humerus, femurs, and potentially clavicles are technically proximal long bones as well. Multiple proximal long bone fractures indicate a high mechanism, right? A lot of energy to break a lot of bones. And remember, bones do bleed. Bilateral femur fractures can result in life-threatening blood loss easily. Even one femur fracture can result in life-threatening blood loss in some cases. Next is a crushed, degloved, or mangled extremity. This one might not be life-threatening if we can apply a successful tourniquet, but if that patient wants to keep their extremity, they're going to need a very high level of care in the near future. Next is an amputation proximal to the wrist or ankle. If a patient chops off a fingertip or something like that, it doesn't necessarily meet these criteria, but anything more than a hand or foot is going to be a step 2 criteria here. Next is a known or suspected pelvic fracture. Remember, we talked about pelvic fractures where it's very, presumptive heavy. We don't always know definitively if a patient has a pelvic fracture or not, and they're really frowning upon an unnecessary manipulation of the pelvis these days. We don't necessarily want to rock it back and forth, but if we find any instability of the pelvis, any severe pain, or any other indication that a patient might have a pelvic fracture, That meets step 2 criteria. Next is an open or depressed skull fracture. This one is pretty intuitive why it's a serious injury. A lot of these patients are going to be entered under step 1 because their GCS probably isn't 14 or 15 if they have a depressed skull fracture, but we have this criteria in case they happen to have a GCS of 14 or 15. And next is paralysis. Any deficit on your CMS checks is going to be an anatomical criteria. The anatomy in that case is going to be the spine. Moving on to step 3, we start to look at mechanism of injury. Remember, when we get into the lower steps here, steps 3 and 4, we can take these patients to lower level facilities, but we should absolutely make them trauma entries, and we might consider taking them to the highest level of care available within a region, especially if there aren't a lot of patients pending at the same time. Your step 3 criteria are your mechanism of injury criteria. So there are a few different injury types we can talk about. When it comes to falls, the height to remember is 20 feet for adults, so that is a second-story roof or higher, 10 feet or 2 to 3 times the height of the child for our pediatric patients. Anyone who falls over that height is going to be a step 3 patient unless they meet step 1 or 2 criteria, because it's always based on the worst finding, remember. When it comes to vehicle versus pedestrian or bicycle or motorcycles, ATVs, golf carts, anything with an open cab, the speed to remember is 20 miles an hour. 20 miles per hour or more of impact, and that is a step 3 criteria automatically. Motorcycle crashes as well, right? Anything with an open cab, anything without the protection of some sort of cage. High-risk auto crashes, we will move on to now. The main thing we're looking for in vehicle crashes is intrusion. This is a bit tricky because older vehicles don't tend to crumple, they hold their shape, but we still see serious injuries, so always keep that in mind when it comes to using your own discretion that we'll talk about later. But we're looking for 12 inches of intrusion into an occupied compartment, so into the actual patient or passenger area of the vehicle, or 18 inches anywhere in the vehicle, rather. So if the hood crumples 20 inches in, that's going to meet step 3 criteria. If there's a foot of intrusion into a passenger compartment, that is going to be a step 3 criteria as well. Next is ejection. This one's pretty intuitive. A lot of those patients are pretty critical. They tend to meet step 1 criteria a lot of the time. But if someone is found outside the vehicle, even partially outside the vehicle, that is a step 3 criteria automatically. Any death in the same vehicle, if there's enough trauma there to kill one person, there's absolutely enough trauma to kill everyone else in that vehicle, so that's a step 3 criteria as well. And the final one is telemetry data. So sometimes you will get dispatched by some sort of crash detection service that will be transmitted remotely, and you might get told in that dispatch information that telemetry data indicates a high risk of injuries, and that is also considered a step 3 or a mechanism criteria for vehicle crashes. If they do not meet any of those steps, we move on to step 4, which is special populations and special system considerations, and at the end of the day, your own discretion if you feel that a patient is going to need the care of a trauma center. When we talk about the elderly, there are a couple criteria, a little bit of trivia to remember. Risk always increases over about age 55, right? So any elderly patients are going to have a higher risk of life-threatening injuries in response to even a minor traumatic event. So we want to take them a little bit more seriously and have a high index of suspicion of hidden injuries. A systolic blood pressure under 110 and a patient over 65 years of age might represent clinical shock as well. Whereas we wouldn't get too concerned with a 22-year-old having a blood pressure hovering around 100 systolic, and a 70-year-old patient under about 110 is when we start to get concerned, because they are typically hypertensive. Their blood pressure is usually high. They also take a lot of medications that can kind of mask other signs and symptoms of shock as just a general consideration for elderly patients. And so we want to take these patients seriously. Any blood pressure under 110 and someone over the age of 65, we want to have a high index of suspicion of clinical shock and life-threatening injuries. A lot of these mechanism of injuries are going to be low impact. So things like ground level falls become very common trauma activations in elderly populations because they can get injured, right? Folks can sustain life-threatening injuries from something as simple as a ground level fall. So we don't want to get a false sense of security just because it's a low mechanism. When it comes to children, the guidelines typically say to prioritize trauma care. If it's a choice between taking a child to a children's hospital or a trauma center, we always prioritize the trauma, but if you're in a big metro area and there's a facility that does both, we want to try to take children to pediatric capable trauma centers whenever possible. Any hospital can always take pediatric patients, but if there happens to be a pediatric specialized trauma center, we want to consider taking our pediatric trauma patients to that facility. When it comes to burns, it's very similar. Prioritize the trauma care. If patients have burns and traumatic injuries, prioritize the trauma. But once again, if there's a facility that does both, if there is a burn center that is also a trauma center, try to take the patients that have both types of injuries to the facility that is equipped to manage both. But always, always, always prioritize the trauma. Anyone over about 20 weeks pregnant, we become a little bit more concerned, not necessarily because of the fetus, but because a baby places a big strain on the mom's baseline physiology. That baby is taking a lot of mom's resources and makes them a lot more likely to sustain life-threatening injuries and to have clinical deterioration because of that fetus they have on board. So we take pregnant patients a little bit more seriously, especially if it's over about 20 weeks. Next is anticoagulation and bleeding disorders. Anytime a patient takes a blood thinner who hit their head, even if it seems like a soft head injury, needs to go to an emergency room, they probably need a CAT scan of their head, and we should take them seriously. They're at a high risk of slow-growing brain bleeds. They might look okay in front of you, but they might end up having stroke-like symptoms a week later because of a brain bleed that's been growing ever since their minor head injury. So anyone who takes a blood thinner who sustained a serious traumatic mechanism or hit their head, even if it seems minor, always needs to go to an emergency room, and they should really go to a trauma-capable facility, at least somewhere that is capable to do a CT scan of their head. Finally, at the end of the day, you always have your own judgment, right? If you think a patient needs to go to a trauma center, you should trust your gut on that one, right? If you think a patient might have injuries that have not yet been found, their vital signs look great, their level of consciousness is great, we don't find any injuries that meet our anatomical criteria, maybe the mechanism wasn't that impressive, but it still concerns you, and they don't meet any special population criteria, you have your own judgment. You can always make that decision. It is ultimately up to you where you take that patient. Follow your local protocols, your local guidelines, but you have that ability to choose where you're going to take your patient. Anytime there's doubts, we should take trauma patients to a trauma center, right? Trauma is a very specialized level of care. Trauma surgeons do a very specific job that can't be done by other physicians, right? An ER physician cannot save a trauma patient's life if they don't have an operating room, right? Trauma surgeons do a very specific job, and they're the ones that are really going to save our trauma patients. So if there's ever any doubt, we want to err on the side of taking trauma patients to a trauma center when it is reasonable and appropriate. So I'll run you through a list of some of the more common blood thinners that are out there. Remember, this is an important criteria because if your patient has a head injury or any significant injuries for that matter, and they do take a blood thinner, they're going to be at more risk of bleeding, of a brain bleed or any sort of internal hemorrhage. And so we might consider taking them a little more seriously than we otherwise would. And we're going to have a higher index of suspicion of some potentially hidden injuries, especially bleeding types of injuries. So some of the more common ones are warfarin, otherwise known as Coumadin. That's probably the most common blood thinner that is out there, at least currently. Pixaban, otherwise known as Eliquis, Rivaroxaban or Xarelto, Dabigatran or Pradaxa, heparin, Edoxaban or Savesa. Those are some of the more common blood thinners you'll find out there, but there are more than that, right? So always remember to ask patients after traumatic events if they do take a blood thinner and treat them appropriately, right? Have a higher index of suspicion of hidden injuries if they do take a blood thinner, especially if trauma to the head is involved. Aspirin is not technically a blood thinner. It does have similar effects, but we call it specifically a platelet aggregation inhibitor. So it's not technically a blood thinner, does not count for these purposes at least. So that is it for the course here. Just a quick review of what we've covered. We've covered a lot of information. Hope this was a good introduction into musculoskeletal injuries and kind of trauma care more broadly. But musculoskeletal injuries are very common in response to traumatic events, and all sorts of injuries are common in response to traumatic events. Most isolated musculoskeletal injuries are not going to be life-threatening, so remember to prioritize those immediate life threats. Remember, bones do bleed though, so big femur fractures, pelvic fractures are still life-threatening, even though that's just a bone injury, because we've got to remember that bones do bleed. We've got to be very careful with the spine, especially the cervical spine, because that can quickly take away a patient's ability to breathe if we cause an injury there. But most extremity fractures and minor musculoskeletal injuries really just come down to wound care, and we don't want to get distracted away from life-threatening injuries. Always, always, always when it comes to trauma, and any patient encounter for that matter, Prioritize life threats and rapid transport to patients who need them. Remember, the big thing that makes a difference in critical trauma patients is the amount of time it takes to get that patient in the hands of a trauma surgeon and the specialists who are actually going to fix them. So we don't want to delay transport by splinting an extremity fracture or doing minor wound care. Those things can happen en route when we get time to do them. We prioritize those life threats and rapid transport when there's serious trauma involved. Finally, just make sure to practice these skills. There are a lot of skill sheets we've talked about. All the splinting, the long backboard, cervical collar application, traction splints. A lot of skills when it comes to musculoskeletal injuries, and we have to practice those often enough to be comfortable performing them, right? You got to perform a skill 20 times perfectly in the scenario land before you're really equipped to do it well under stress. So make sure we're practicing those skills. We can't go over skills in a virtual course here. That really comes down to you getting out the equipment and practicing going through those skill sheets and performing the skills that we need to perform to do this job. So that is all I got for you. There are a lot of references here that you can go ahead and take a look at if you'd like a little bit more information on anything we have gone over. I hope this course was a good introduction for you into musculoskeletal injuries and trauma care. Thanks for watching the course and have a great rest of your day.
Now let's transition into some multiple choice questions.
First question. You are dispatched to a football field where a 19-year-old male has a reported arm injury. Your scene is secure and you take BSI precautions. You have made patient contact, assessed vital signs, and are now performing a physical exam. While splinting a deformed humerus, the highest priority is to: options include assess CMS before and after the splint is applied, ensure there is no change due to splint application, splint in such a way that the deformity is still visible, immobilize the arm completely in a fully extended position, or splint and transport as quickly as possible. The correct answer is assess CMS before and after the splint is applied and ensure that there is no change due to splint application. Circulation, motor ability, and sensation, or CMS, is the highest priority and more important than complete immobilization. Next question. You arrive on scene to find a 78-year-old male who caretakers say broke his hand during a ground-level fall. On examination, you note a 1-inch laceration on the dorsal surface of the hand, as well as a large accumulation of blood under the skin. The patient denies musculoskeletal pain and has full range of motion. What condition are you most likely dealing with? Options include hematoma, hemangioma, fractured scaphoid, or fractured phalange. The correct answer is hematoma. The accumulation of blood under the skin should tip you off that this is a hematoma rather than any of the other answers. Next question. You suspect a patient may have sustained a possible fracture or sprain. Proper care of this injury would include which of the following? Options include having the victim try to bear weight on the injury, having the victim move the injured area to assess its mobility, straightening the injured body part and applying ice, or putting a bag of ice on a towel and placing it over the injured area. The correct answer is putting a bag of ice on a towel and placing it over the injured area. If you suspect a sprain or fracture, advise the patient to not move the injured area. Stabilizing and icing that area is the best course of action. Next question. You note crepitation in a patient who is complaining of chest pain after a fall from his ATV. You know that crepitation refers to which of the following? Options include deformity in an extremity, the sound that occurs when broken bones rub against one another, shock, or high blood pressure. The correct answer is the sound that occurs when broken bones rub against one another. Crepitation occurs after bones have fractured and rub against one another. The sound they make is called crepitation. Next question. You respond to a 52-year-old female with pelvic instability after a ground level fall. She is in a significant amount of pain in her left hip/pelvic region, and vital signs are currently stable. Of the following courses of treatment, what should you consider most? Options include IV pain medication, pelvic splint, and C-spine precautions, rapid transport, C-spine precautions, trauma system entry, IV pain medication, Sager splint, C-spine precautions, and trauma system entry, or C-spine precautions, trauma system entry, Sager splint application. The correct answer is IV pain medication, pelvic splint, and C-spine precautions. The pelvis can hold over 1,500 mLs of blood and can easily put a patient into shock. Along with pain medication, if not contraindicated, you should apply a pelvic splint and consider C-spine precautions. Under most circumstances, this type of injury would not warrant a trauma system activation. A Sager splint is for femur fractures and is contraindicated with suspected pelvic fractures. Next question. You are responding to a trauma at a local bar, and dispatch information indicates that a college student fell from a second-story balcony. Bystanders state that the patient landed with his arms outstretched in an effort to catch himself. What is the most probable injury this patient will present with? Options include Cole's fracture, Smith's fracture, green stick fracture, or humeral fracture. The correct answer is Cole's fracture. Cole's fractures are a result of a person falling forward with their arms outstretched in an effort to break their fall. A Cole's fracture is a combination of a compression and flexion fracture of the wrist that occurs from weight loading at the wrist joint. Next question. You are called to a baseball field where two players have collided. A 17-year-old male is complaining of shoulder pain, and you notice an anterior bulge on his left shoulder. What is the most effective method of immobilizing this injury? Options include an air splint with the left arm immobilized in the extended position, an air splint with the left arm immobilized in the flexed position, a sling to support the left arm and swath to secure the arm to the body, or a sling to support the left arm and swath to maintain downward traction. The correct answer is a sling to support the left arm and swath to secure the arm to the body. The injury is to the shoulder and the arm needs to be immobilized so that movement of the extremity is minimal. You would never apply traction for a shoulder injury. Next question. Your 4-year-old patient has sprained her ankle. You should. Options include treat it as a fracture and immobilize accordingly, immediately transport the patient to the hospital, elevate the injury and administer a mild pain reliever, or apply ice and advise her not to apply pressure to the area until it heals. The correct answer is treat it as a fracture and immobilize accordingly. Pediatric patients have softer bones than adults, and therefore sprains and strains should be treated as fractures. Next question. A horse riding accident results in an abrasion of the clavicle, a contusion of the patella, swelling of the humerus, and a laceration around the orbit. Which of these injuries is most concerning? Options are swelling of the humerus, abrasion of the clavicle, contusion of the patella, or laceration around the orbit. The correct answer is swelling of the humerus. A laceration of the orbit is a cut around the eye. A contusion of the patella is a bruise on the knee, and an abrasion on the clavicle is a scrape on the collar. These three would generally not be life-threatening. The greatest possibility of a life threat in this scenario would most likely be swelling of the humerus or the upper arm bone, which could indicate internal bleeding. This would be the most concerning injury out of the choices listed. Last question. Your 88-year-old patient complains of a shoulder injury after a fall. Her shoulder is painful, swollen, and immobile. It is noticeably deformed, indicating a complete displacement of the bone. Your 88-year-old patient complains of a shoulder injury after a fall. Her shoulder is painful, swollen, and immobile. It is noticeably deformed, indicating a complete displacement of the bone end from its normal joint position. This is most likely A. Options are muscle spasm, subluxation, dislocation, or sprain. The correct answer is dislocation. A dislocation is the complete displacement of the bone end from its normal joint position, while a subluxation is only a partial displacement. A sprain is a tearing of the joint capsule's connective tissues, and a muscle spasm is a contraction of the muscle.
Thanks for tuning in to EMTprep Pulse Check. If you found today's episode helpful, be sure to subscribe, leave a review, and share it with your classmates and crew. For more test prep tools, study guides, and practice exams, head over to EMTprep.com. Until next time, stay sharp, stay safe, and stay on pulse.